So, good afternoon and evening. Welcome delegates again for this the course on nutrition, and I welcome all the delegates. I welcome our ICOG chair, Dr. Lakshmi Shrikhande, to say a few words. This is the third day consecutively, and I welcome all the speakers also. Yes.
Yes. So very good evening, one and all. And I'm so happy that this time FOGSI ICOG is conducting 3-day online course totally dedicated to nutrition in women. And I'm so happy that Vidya has come out with such a beautiful 3-day module where we have covered all the crucial milestones of women's life, that is adolescent age, infertility, preconception, conception, lactation, midlife, and old age. And that is where we OBGYNs have a great role as far as taking care of nutrition of these women is concerned. So I'm sure everyone has been benefited. And today again, we are having talks dedicated to nutrition in infertility, menopause, and oncology. So friends, I wish you all happy learning and hand over back to Vidya for further proceedings.
So, shall we have the pre-test now?
No, you just revise what was
yesterday's. So yesterday we had five talks by eminent speakers, and mainly they dealt with the nutritional risk assessment and the management in these high risk pregnancies. So it also, nutrition plays a vital role not only in the normal pregnancy also, but it also plays a vital role in various pregnancies, high risk pregnancies like hypertensive disorders in pregnancy, where Girija has pointed out about various abnormal maternal adaptation and responses to the pregnancy and its intricate mechanisms. So obesity, anemia, protein deficiency, inadequate calcium in these hypertensive disorders in pregnancy, folates, and vitamin D also seem to be associated with occurrence of preeclampsia. Likewise, dietary malpractices such as excessive carbohydrates, trans fats, and salt intake can also contribute to these disruptions. So evidence also suggests that optimum protein consumption, folates, DHA in the diet of a pregnant woman can influence better pregnancy outcome. So our antenatal care has to focus on balanced maternal nutrition again, and which is also a cornerstone of every pregnancy. The second talk, which was again by Dr. Hema Divakar, where she touched upon the medical nutrition therapy, which remains the cornerstone of the treatment for GDM. And it is seen in 80 to 90% of this GDM can be managed by a medical nutrition therapy alone. So this diet plan, considering proper distribution of calories, and mainly it is a carbohydrate what determines your blood sugar. So proper counseling in a GDM patient with carbohydrate counting, type of nutrient, and meal time will surely help in crossing the important phases of this surge, what we say is cortisol surge, which is seen, that is Dawn's phenomena in the early morning. No? So those can be crossed over by proper advice on the calorie count and the signaling system, especially if they can be told about what is good, what is bad, what is a good cholesterol, means glycemic index of the every food if they know, and the glycemic load. She was talking about the glycemic load as well. So this is very important factor in the management of GDM, and everybody should know about this. Then the talk on fetal growth restriction and what should be the medical nutrition in these patients, how there was any evidence on arginine, that was really eye-opener for us. The talk was given by Dr. Jayanti. The immunocompromised woman, what should be the nutritional therapy, like HIV as well as other immunocompromised diseases like tuberculosis. So they require specific proteins and the means vitamins and minerals in right proportion, and the antioxidants, because the oxidative stress they have in these immunocompromised women. Anju Soni pointed out what should be the proper diet these immunocompromised women should have. The calcium and vitamin D and osteoporosis was dealt by Dr. Meeta, and it was really, really well taken by all the delegates of yesterday's our ICOG webinar. So vitamin D has a key role in regulating functions of female reproductive system, and calcium, vitamin D is very, very essential for calcium absorption. So this and the proper dosages and the exposure to the sunlight was explained by Dr. Meeta. And there were so many questions to share her presentation also. As Dr. Lakshmi presented her talk about the food safety, and never ever we see the labels, what is there, what is not there inside, and we go on consuming these consumption of these are very fancy items and which are kept with very attractive labels. So we should see these labels and we should consume what really is beneficial for us. So please see the label whenever you are entering any malls. Fasting and its effect was told by Dr. Nalini Anand. Fasting in moderation is good, but should be under medical supervision, especially in cases of diabetes, PCOS, and thyroid disorders. It is not a fasting which will reduce your blood sugar. It will again lead to some ketoacidosis and undesirable effects. So fasting you should be very careful in these patients. So it should be regulated. So calcium, vitamin D, its effects on the body, and the menopause will be dealt today with by Dr. Revati. Then oncology is a very special subject which will be dealt by Dr. Bhagyalakshmi Naik, oncology and nutrition. Dr. Parikshit Tank will be talking about male infertility. Dr. Ritu Khanna, who is our food, drugs and medical surgical equipment committee chair. And also my very dear friend, she will be talking on the micronutrients in female infertility. We have got very nice at the end, very great panel on all the topics which were covered on 3 days. Dr. Revati, I have not forgotten you, and you will be talking on nutrition and menopause. So welcome delegates. I hand over this proceeding to Dr. Ritu Khanna, and I request our IT person to start his pretest.
Yeah. Jignesh will be posting the link. Friends, open your chat box. The time given to you is 10 minutes. Jignesh, post the link. Yeah, so link is been posted and start the timer also. Jignesh, timer लगा?
Yes, ma'am.
Great. Time up.
So, yeah.
Yes,
So I think we,
yes, Ritu.
so we end with the pre-test now. And I think it's amazing to have a certification course on nutrition. And with the third day of it so fantastically running, we thought, what can we discuss, on nutrition? But today we learned that even 3 days are less for the same. Thank you so much. Thanks also to Dr. Chamila and Dr. Vidya Tobi, madam, for making me a part of this such an innovative academic certification course. And I'm sure that we're going to have it as a great learning session. So with this, it's an honor for me to introduce a stalwart and a very, very meticulous personality, and that's Dr. Parikshit Tang. He's a consultant Ashwani Maternity and Surgical Hospital, Center for Endoscopy and Assisted Reproductive, Mumbai, consultant Jupiter Hospital, Thane, and he's the honorary professor, Pacific Medical College, Udaipur, and a consultant for 16 ART centers. He's the treasurer of FOGSI, the chairperson of Safe Motherhood Committee in the year 14 to 17, postgraduate teacher and examiner, College of Physicians and Surgeons, so many awards to his honor, and over 100 peer-reviewed journals, and so many, much more. So over to you, Dr. Parikshit Tang, for your presentation.
Thank you. I understand that this is a course and, everybody is extremely keen to get to the material. And I will honor that sentiment and get going right away. I'm sharing my screen. I hope that it is visible and it goes on to the slideshow mode.
Yeah, it's visible.
Yes, sir.
Okay, right. So right at the outset, I must thank the chairperson of the ICOG, Dr. Lakshmi Shikhande, for having this concept of a nutrition-based course. I mean, that's something which is so day-to-day, but I think we probably don't talk about it academically enough. And of course, the entire team of ICOG, the vice chairperson, Parag Biniwale, secretary of ICOG, Dr. Ashok Kumar. Of course, the FOGSI team is always there. President Dr. Pai, Secretary General Dr. Madhuri Patel. But I must make a special mention of the conveners and the people who have been really looking after this course. That's Dr. Vidya Thobi and Dr. Ritu Khanna today. So thank you very much, Charmila, also Dr. Ranjana Khanna, Dr. Kiran Pandey have been the conveners, and it's great to be taking part in today's discussion. And I'll cover micronutrients and male infertility. Now, when we talk about male factor in subfertility and in couples who are not conceiving, what is it that we exactly need to be focusing on? Yes, I mean, the obvious thing is an abnormal semen analysis. Either the man has oligozoospermia or asthenozoospermia or terato or a combination of all these things, or he's azoospermic. But male factor is much more than that. There is male sexual dysfunction, which will contribute to the problem. And of course, there is a lack of education or knowledge, interest, a very low frequency of intercourse. All these things put together is the really broad definition of male factor. And believe me, nutrition and micronutrients play a role in each of these aspects of the male factor being the center focus in a couple who is facing fertility problems. Now, the basic and the most common thing that we ask couples to do is a semen analysis. And it should be, of course, a well-collected sample, etc. But what has been happening to the semen parameters or the semen characteristics over the last 30 years or so? If you observe the first WHO manual in 1980 and compare it to what we have today, there is a progressive decline in all the parameters which are stated as normal. So we started as a cutoff of 20 to 200 million being a normal count, and today we are happy with 50 million. The sperm volume was supposed to be 2 ml or more, now 1.5. motility more than 60%, today 40%, and progressive motility is a concept which we now understand much better than in the 1980s. So if you observe every parameter related to sperm count, motility, etc., has declined in what is defined as normal. So is it really true that sperm counts are declining? Semen parameters are continuously being redefined, and every now and then we see these kind of headlines in the popular press. Sometimes I jokingly ask myself that have men become lazier at producing sperms, or have they finally become more efficient because there's no end to fertility as such, as far as the world population is concerned? Yes, something has definitely changed. And what this something comprises of is the environment. Now, the environment has multi-level effects. Of course, it affects the overall health of this man in terms of his cardiorespiratory function, immune function, cellular function. But it changes the reproductive milieu from internal disruptors, including obesity and smoking. All these put together are called environmental hormone disruptors, or EHDs. The environment is not only what is outside, it's not the atmospheric pollution or what is around you. It's also what is inside of the man, which affects the testicular function. We all know that we need to do semen analysis, but every man with a normal semen analysis may not be fertile. In fact, semen analysis is only about 60-70% predictive. And that too, it starts becoming predictive after there has been an adequate trying time that a couple has. So there's much more to male infertility and poor sperm analysis than what we are exposed to. So right from aging, lifestyle, pathophysiologies, and environment that I spoke about, that's everything which is going to affect male infertility. And in terms of lifestyle, I would like to draw your attention to obesity, alcohol and tobacco consumption, nutrition, the energy intake, and of course, additives and recreational drugs, which also affect the male fertility. One of the things that is now increasingly being used to study the impact of all these various factors is the DNA fragmentation index. And it's something which tells us what's the degree of sperm damage at a genetic level that has happened in this particular semen sample today due to oxidative stress. And various techniques are available, and the results are expressed as a percentage. I mean, if the DNA fragmentation is less, so there's less fragmentation, that means there's more intact semen, and higher the fragmentation index, obviously that you will call a poor quality or a poor quality semen. Now, of course, it's a costly technique, but it does give us some ideas. It just doesn't stop at semen analysis. One has to think a little beyond just the numbers and the motility. And this is really the cornerstone of where nutrition and micronutrients come in. The oxidative stress which the sperm cell is facing at a cellular level, at a genetic level, is where we are headed in terms of the future of male infertility evaluations, male infertility therapies, and of course, indicative of today's topic of micronutrients. What will you do when you are faced with male infertility? This is the typical decision-making tree. And the first couple of questions are really relevant today. What is the natural fertility potential that this couple has? And can the male fertility potential be improved? And that really is the place where we are going to talk about micronutrients. Yes, of course, there are advanced techniques and complex problems that the male may have. Say, for example, if the man is azoospermic, no amount of nutritional change, micronutrients, etc., is ever going to help him get to a point where he can impregnate his wife. But there are more than the majority which are at that borderline kind of semen analysis. And for all these men, the second question which I've highlighted, can the male fertility potential be improved, is very important, because it can not only increase the chances of a spontaneous conception, but it can also downstage their treatment. I'm borrowing terminology from our oncology colleagues, but instead of doing IVF, this couple might get a pregnancy from IUI. Instead of doing IUI, they may get a pregnancy just on their own. So this is what happens when male fertility potential can be improved. Yes, we all talk about common sense advice, a healthy diet, good lifestyle, balanced approach to nutrition, exercise, and a reduction of stress. We advise this left, right, and center, but I don't know how many men actually are able to follow it. When we talk about male infertility and the role of nutrition, macronutrition is much more important than micronutrition. Today, obesity is the one single most important growing reason why men are facing fertility issues, because of so many different pathways which have been outlined here, right from an effect on DNA methylation to the endocrine system, to the fact that the scrotal temperature gets raised, to the fact that obesity contributes to sexual dysfunction. So many mechanisms by which obesity, which is very central to the nutritive aspect of male infertility, is going to change the playing field. But even in people who are obese, micronutrients have a role here too. So it's not as if you can ignore micronutrients and just say that, well, this is all obesity related and there's nothing much that we can do. In fact, they have an equal need for micronutrition as compared to the man who has a normal BMI. We all are in the search for the perfect sperm tonic. And believe me, all that we do are empirical therapies. So remember the tenets of empirical therapy. Do no harm, don't waste too much money, don't waste too much time, and follow the 3-month rule. That means if you want to give some supplement, some kind of therapy for male infertility, and you want the couple to have a serious attempt with that, give it for at least 72 days, roughly 3 months, because that's the spermatogenesis cycle, and you want to see whether the intervention is creating an adequate impact with the changes in the semen analysis. A huge list is available in terms of what you can do, what you can give the man. Antioxidants, zinc, and multivitamins. There are hormones and hormone-like agents, L-carnitine, coenzyme Q. Then, of course, there is the traditional therapies or the herbal therapies, and sometimes just verbal therapy that, you give some kind of a placebo and the man feels more confident about himself, and that may overcome sexual dysfunction. It won't really change hardcore parameters. The central role really goes into the oxidative stress that the spermatogenesis cycle is subjected to in the infertile man. And this oxidative stress comes from the environment in terms of temperature, the environment hormone disruptors like phthalates, radiation, diseases like varicocele, genital tract infections and fever, and of course lifestyle, which amounts to obesity, smoking, and reproduction at a later age group. And all this is going to increase the DNA fragmentation, which subsequently makes this man infertile. Today, there is a lot of work which is being done on SOD that is superoxide dismutase. And this is one mechanism really by which we can potentially change the degree of reactive oxygen species that the sperm is subjected to. So when there is an increased level of intracellular SOD, ROS, it activates the signaling pathway, and this causes an expression of antioxidant enzymes, which in turn detoxify the spermatogenesis pathway and improve DNA integrity in the sperm. A lot has also been talked about, studied in terms of what vitamins can do. And here they are going to protect the sperm by two mechanisms: oxidative stress reduction, which makes the sperm membrane more stronger, there's better integrity, and also it enhances the mitochondrial function of sperms. So you've got more intact normal sperms and you've got more motile sperms, which are ultimately what we are looking for in terms of male infertility treatment. And similar effects have also been seen by other mitochondria enhancers like CoQ10, L-carnitine, and quercetin. Now, all of these have very, very complex mechanisms of action. And typically as clinicians, we don't get into the biochemistry and the pharmacology. But suffice it to say that essentially multi-agent therapy is what we are looking at, because this will allow action at different levels and pathways of spermatogenesis. And the target is really to reduce oxidative stress and improve cellular function by mitochondrial mechanisms. So this is how they all act. SOD-based antioxidants, lycopene, carnitine, CoQ10, zinc, all of them have some role. And these are all the common micronutrients that we are increasingly seeing, which are packaged and they are marketed in terms of what is typically called as a sperm tonic. So if we look at Cochrane reviews about antioxidants, for example, this is not the right way to read a Cochrane review. An increase in live birth rates for partners of subfertile men taking antioxidant supplement. But actually, what does the trial say? It's findings from 3 small trials and for those couples who are a part of an assisted reproductive program. Sometimes the last part of the sentence gets forgotten, and it completely changes the meaning of the role of micronutrients and antioxidants. More work which was done from 2011 to 2019, and this expanded the number of studies, but yet the quality of evidence remains low. There is some improvement in the live birth rates and the clinical pregnancy rates. The miscarriage rates don't change, and by far and large, all these micronutrients and supplements are quite safe and they don't really cause too many side effects. So my parting thought is that a trial of empirical therapy should be just that, a trial. It's not a challenge to the testes, to the man or the doctor who's prescribing it. So when it's time to call it off and move on in terms of what you're doing for this man who's facing a fertility issue. As they say, let food be thy medicine and medicine be thy food. It's important to incorporate all these micronutrients as far as possible into a diet which is wholesome and attractive, so that this is something which is sustainable and the man can continue to use. With that, I come to an end for today's talk. Thank you.
Thank you so much, Parikshit sir, for that fantastic in-depth presentation on micronutrients and male infertility. And I think we had so much of learning every time our patients coming, some of them, sir, they are always in a hurry. I've just come, I've got just this much time. I think there's more of an oxidative stress which increases rather than decreasing that, And just a small question to you, sir. Like, should we in all our oligoteratos, should we do the DFI in all these patients? Do you get them done, sir? What is your message for us, sir?
No, frankly, I don't. ask for that test routinely for every OATZ. But I think we need to identify which couple to advise this to. So my criteria for advising this is for actually unexplained infertility. See,
Right.
if you have a man who is OATZ, he's going to have a bad DFI anyway. So we are not adding anything much to the whole situation. When you prescribe it for somebody who has unexplained infertility, those who have unexplained failures of fertility therapy, then there is now a target which you can address, and hopefully you can correct that. So no, I don't advise it routinely for all OATs.
Yeah, unexplained. So, and I think there's just so much of basket of those micronutrients, and these companies come to us with so many combinations. So is it particularly, sir, that you pick up it's a motility which is affected, so I choose this micronutrient? Is it the morphology and this micronutrient is going to affect, sir, or you give a combination of those?
No, I think it's very difficult to localize that this particular micronutrient or vitamin is going to act only on motility or only on count or only on the morphology. So no, I believe that we should in fact look at a multi-agent kind of an approach. And my current thought process is that whatever combination we are using or prescribing, there should be coenzyme Q10 and carnitine. I feel these two are essential, and then whatever other stuff which makes up the formulation.
Right. So thank you so much, sir, because that's very essential. We really cannot understand what combinations to pick up. And I think we shouldn't lose the most important ones, as you suggested to us, and that's the CoQ and the carnitine, sir. So I think we're not with any other questions. Vidya, madam. So can we proceed with the next, I think?
Yes, I can't see Vidya. Thank you so much, Parikshit. Yeah, Ritu, yeah, please invite the next speaker.
Yeah, so it's my presentation, so I think I can share the screen to start my presentation. And yeah. So thank you so much once again, our ICOG team headed by Dr. Lakshmi Madam, Dr. Parag, Dr. Ashok Kumar Sir, and of course our FOGSI team, our President, Dr. Rishikesh Pai, Madhuri Madam. And it's an inspiration to bring out, I don't know how Madam inspired us to get this course on. And that was a fantastic thing that I got to speak on, and that was on micronutrients in infertility, female infertility. So if we are moving across, just 1 minute. Yeah. So micronutrients in, yeah. So it's over the last few decades, we found that fertility has declined globally to the unprecedented low levels. And we were just putting so many medications to our patients. We never thought of nutrition. And I think why we thought of nutrition was because in more than 70% of the couples, a problem with ovulation could not be identified. So this motivated now identifying potentially modifiable risk factors. Can we have them? So this micronutrient status was one of the modifiable risk factors that may have an impact on the female fertility, as essential vitamins and minerals have important roles we saw into so many physiological processes that are involved. So if we look into the recent evidences, the women who are diagnosed as infertile in a proportion of women of the childbearing age, if you take in general, are some of those who've been really struggling to conceive. They have lower than the recommended levels of the micronutrients which have been reported. In more than half of these infertile women, there were low B12 levels which were seen. And the women who were infertile had lower B6 levels than the fertile women. The women may be less likely to conceive if their vitamin D level intake is below the recommended, or if the serum 25 hydroxyvitamin at what they were at risk for inadequacy or deficiency. So other literature said that vitamin D deficiency was associated with conditions that decrease fertility as PCOS, and they are going to adversely affect the outcomes of infertility treatment that they're undergoing. So it's been also reported that the total antioxidant status is lower in the serum of women who had PCOS, as well as in the peritoneal fluid of those women who had an idiopathic infertility. Now, in the industrialized countries, a proportion of the women of childbearing age have got lower than the currently recommended level of certain micronutrients, and they were detected to be folate, the B12, the vitamin D, the calcium, iodine, iron, and selenium. And so that means that the physiological environment for conception to pregnancy or pregnancy must have been really suboptimal. So whenever we're taking a healthy diet, do we still need to take a supplementation? Let's see. Even in the countries where there's a very, very easy access to fresh, nutritious food, it may be certainly difficult sometimes to yet to consume a very healthy diet, and that's number one. The second is the social, economic, educational, ethnic, cultural, and genetic factors can also affect the preconception diet, leaving many women of childbearing potential with a suboptimal micronutrient status. Not only this, the food that we eat are not always packed with all the nutrients that are essential for effective working in our systems, and due to a change in the methods of farming, the chemicals that are being added to the soil. So the depletion of the natural minerals due to certain over-farming and the kinds of atmospheric pollutants, like we do not get a proper nutrition. And so that's the reason that we ended up, yes, we need supplements of micronutrient to give a very, very optimum environment. So the micronutrients, what are these? They're just vitamins and minerals, but they're very, very small quantity, which we need because the body is not able to make up into sufficient amount. Do they give us energy? No, they do not give us energy. Then why do we need them? Because they're essential for the catabolic and the anabolic processes. So if you take vitamins, they're organic substances. The minerals are the inorganic substances or nutrients. Then what are the antioxidants? These antioxidants are a specific category of the vitamins and minerals which have an ability to deactivate naturally occurring damaging compounds in the body. And these compounds are the mischievous free radicals, and thereby these antioxidants promote good health. And some of the antioxidants are vitamin A, C, E, selenium, astaxanthin, and lycopene. So adequate levels of micronutrients are important to restore the female fertility, which has been looked into the literature for the oocyte quality, maturation, fertilization, implantation, and thus to optimize the reproductive health. And studies also have shown that iron, folic acid, vitamin D, E, they have a beneficial role. And of course, if you use the multivitamin supplements, they decrease the risk of an ovulatory infertility. And so we have so many micronutrients. We know about homocysteine, that B12 and folic acid are essential to run the cycle. So vitamin B6, B12, and folic acid reduce the concentration of homocysteine. But what happens in the infertile patients? There is a homocystinemia. So therefore, that hyperhomocysteinemia is going to decrease the probability of conception. So here is where B6, B12, folic acid acts to reduce the concentration of homocysteine. So the B group of vitamins and folic acid, when they were administered, they counteracted the hyperhomocysteinemia effect. It's like we supplemented metformin inositol if you've given 2 grams with another 200 micrograms of folic acid to this patient for 12 weeks. There was a significant improvement in the hormonal parameters, and also it restored the menstrual cycle in so many patients with amenorrhea and oligomenorrhea too. So insulin resistance, obesity, elevated homocysteine were associated with lower levels of B12 concentrations, and this is how they were helpful in these patients. There was also a positive correlation which existed between the insulin resistance, the high homocysteinemia levels, which has been shown to improve conception as well as treat not only conception, but sometimes these patients who have premenstrual symptoms and, of course, going into depression and anxiety concerns. So the importance of nutrition at the molecular level is very well established, and numerous processes in the DNA synthesis, they're dependent on the minerals like zinc, copper, selenium, and of course, vitamin B, folate, and other antioxidants. So folic acid, it's important for the oocyte quality, the maturation, the implantation, the placentation, the fetal growth, and the organ development. So if the subfertile women took a multivitamin with 400 grams of folic acid for 3 months, 26% had a pregnancy as compared to 10% who were in the placebo group. So the evidence suggests that the higher consumption of the pre-pregnancy folate is going to lower the risk of the infertility outcome. So 3 months of even folic acid 1 milligram reduce the level of homocysteine in these hyperhomocysteinemic women with PCOS2. Vitamin D, we see the vitamin D receptors are distributed throughout the reproductive tissue, and the vitamin D, therefore, has got an important role. If you look into this whole slide, the effect of vitamin D on the ovarian granulosa cells responsible for the steroidogenesis, as well as on the immune system regulation, it is there that these receptors are everywhere. In the decidua, in the placenta, in the ovaries, in the endometrium, in the pituitary glands. So that means vitamin D has a definitive role into these patients. There was a prevalence of vitamin D deficiency. As much as 70.3% of the infertile PCOS were found to be vitamin D deficient, and 20% were found to be vitamin D insufficient, and only 9% of these patients had vitamin D levels. Therefore, the serum levels of 25-hydroxy are positively associated with the sex hormone binding globulin levels, negatively associated with hirsutism and parathyroid and hyperandrogenism. So there was an association as per the evidence of the low level of vitamin D and the insulin resistance, and also the association of low level of vitamin D and obesity, vitamin D and sex hormone binding globulin, vitamin D and FAI, and vitamin D supplementation improved not only infertility, but even the menstrual frequency and their metabolic parameters. If you look into this chart, if the patients were given vitamin D, look what happened to the AMH, the insulin levels, and the serum cholesterol levels, and the LDL cholesterol levels. They were all much, much better. Therefore, the implementation of 50,000 IU is beneficial for PCOS patients who are going even into their IVF cycles. Now, this is the fecundity and the probability. So there is an association between 20-hydroxyvitamin D and fecundity among the participants from the time to conceive. And when they were given this vitamin D, the estimate probability of taking longer than 6 menstrual cycle to conceive, look at that. When it was less than 20, it was much more. And when it was 40 to 60 or the levels were better, the time to conception was much less. So an estimated of 10% higher fecundity with each 10 nanogram increase in the level of vitamin D. We also understand that reactive oxygen species are very, very necessary for the normal cell functions, and there has to be a balance. We have the scavenger's defense mechanism in our body, but whenever there is an excess of production, like we had in the male infertility too, of a smoking, alcohol, the extremes of body weight, the exposure to environmental toxins, the advanced maternal age, they're all going to impair the physiological female reactions. And what are the physiological reactions? Those are the maturation, the ovulation, the luteolysis, and the follicle atresia. And this can lead to infertility and so many conditions that we're going to come across right now. So there is going to be an increase in the levels of reactive oxygen species and the nitrogen species, and the sources of these could be exogenous or endogenous. The endogenous we understand, and of course we have our lifestyle factors, and the undernutrition, recreational drugs and alcohol and all would be the exogenous, and therefore they lead to so many pathologies like PCOS, endometriosis, preeclampsia, unexplained infertility, and of course the preterm labor, spontaneous, and IUGR. So these are all the reactive species that we will be seeing and encounter when these are raised. But we do have a defense mechanism which keep on acting. But look at this, they act enzymatically or the non-enzymatically. In the enzymatic, we have the SOD, which we had Dr. Parishkitsa mentioning this. And we also have a non-enzymatic oxidants like C, E, zinc, selenium, and beta carotene. Now, how did these trouble us? They just open up the ionic channels, and there's a release of calcium from the endoplasmic reticulum and resulting in a mitochondrial permeability. These ROS may cause protein modification. They may cause a lipid peroxidation and DNA oxidation. That is, mitochondrial DNA is much prone to this attack because of the presence of oxygen in the ETC and the lack of histone protection, and there is no repair mechanism in the mitochondria. So whenever you give an antioxidant, what does vitamin DE do? It's just going to break this chain reaction due to its lipid solubility and the hydrophilic chain, and that's how it's going to help us. So now there's going to be damage to the DNA of the oocytes and spermatozoa, and therefore there's going to be a defective fertilization. And of course, if it doesn't stop here, it's going to induce the apoptosis, and thereby this patient ends up into an implantation failure, an abortion, or an embryo fragmentation. So if we go into this PCOS patient, there is a hyperglycemia. So what happens? From the mononuclear cells in response to this hyperglycemia, there is an oxidative stress, and that contributes to a pro-inflammatory state, and therefore an insulin resistance and hyperandrogenism, and also this occurs independent of opacity. So we have to take care even in the lean PCOS. So in these patients, there's increase in oxidative stress, and they're going to suffer from the increases in the cardiovascular and the hypertension and the obesity. So if we want to take care of the long-term events, we need to take care of this oxidative stress. So mitochondrial dysfunction generates levels of ROS and releases from the mononuclear cells also the TNF alpha. But how is this important to us? This TNF alpha is a known mediator of insulin resistance, and therefore it's a central etiology to a polycystic ovary. There is an oxidative damage to the lipids within the cell membrane. So therefore, the oocyte follicle and the ovarian follicle and the oocytes are going to be permanently damaged. But is there any evidence? Yes. In these patients, you get a higher DNA damage strands compared to the controls. You have high levels of MDA. You have high levels of C-reactive protein, saying that they are biomarkers of an inflammatory condition. So when the antioxidants are less in the ROS or more, there's a granular cell luteinization, progesterone decreases, there's a luteal phase decrease. On the other hand, the estrogen maturation, and therefore a poor quality and infertility. In cases of endometriosis, the peritoneal fluid has shown increased levels of a pro-inflammatory chemotactic cytokines. So increased lipid peroxidation, and therefore the F2 alpha and the heat shock proteins are both increased in this endometriosis. What does it cause? There has to be an apoptosis. But no, when we have this reactive oxygen species and the RNAs, there is going to lead to an anti-apoptosis. And so this condition will never be cured. And what happened was, this was a study where there was this was a 504 women who were detected by laparoscopy. Yes, they have an endometriosis, and they were suggested that diets lacking could have could not be lacking or the antioxidants. So these may predispose. So they were given vitamin C and E for 4 months, and it was found that when the markers were detected of the ovarian oxidative stress, it was found to decrease. So 15% of the couples of infertile, unexplained infertility, there was found to be a contribution to the increased levels of MDA detected in the lipid peroxidation. And therefore, when they were given N-acetylcysteine, which was a powerful antioxidant, they improved and showed good results. So if you look into the micronutrients, we have the iron, we have the folic acid, the B complex, the carnitine, the vitamin A, D, E, C, selenium, arginine, magnesium, and zinc and astaxanthin. So if you give vitamin E to your patients of unexplained infertility who are undergoing the ovarian stimulation, what does this do? There was a significant increase in the endometrial thickness. And why was it so? Because it has got effects of being an antioxidant. And so it reduced the oxidative stress. And of course, its anticoagulant effects by increasing the endometrial and the follicular blood supply. When antioxidants like CoQ, which said it's very, very important, and it take care of the oocyte too. It's an important component of the mitochondria, so an energizing component. And if this were given vitamin C and E, it had an antioxidant defense mechanism, and CoQ regulated steroidogenic enzyme functions dependent on the cytokine P450, and that led to inactivation of the P450 steroidogenesis in the luteal cells. So when given CoQ with vitamin E for 8 weeks, it was found that the sex hormone binding globulin concentrations were improved. Zinc, an important component required for the maturity and ready for fertilization, sexual development. And so when they were inadequate levels, could not stimulate the tyrosine kinase and the insulin receptor in this PCOS patient. Therefore, for insulin resistant, it's very, very important. These are so many foods in which you get zinc, the nuts, the grains, and of course the flax seeds. So apoptosis is essential for regulation of the follicular atresia. The degeneration of corpus luteum and endometrial shedding is all influenced by the folate and the zinc. Magnesium, selenium, iron, and sufficient vitamin A, of course, is very, very important factor for the oocyte quality and the blastogenesis. So therefore, if you enumerate A, C, E, help to defend against ROS, and micronutrients and others have got antioxidant properties. They are folate and zinc are involved in the formation or by the activity of the superoxide dismutase, and these acting by this are copper, manganese, and zinc. And therefore, they protect the DNA and the other vital molecules against oxidative damage, which would otherwise have induced apoptosis. So selenium, zinc, pentoxavalin, very strong. Astaxanthin needs a special mention, 4 milligram BD when given. It is a unique structure. It's got 13 conjugated double bonds and of course hydroxy group at 3 and 3, therefore significant greater antioxidant property. It's highly polar and so therefore the membrane integrity is very, very important, and that's strengthened by this molecule, and it may help in vivo to avoid the lipid peroxidation also. So melatonin, which is taken up nowadays, it's synthesized in the pineal gland. It's called as a broad spectrum. It's a suicidal antioxidant. And of course, it enhances not only itself acts, but it's going to enhance the activity of the other endogenous antioxidants, glutathione and superoxide, and it can act in synergism with vitamin C, E, and glutathione also. And therefore, it's very important as worm scavenger in the ROS. It increases the antioxidant enzymes, reduces DNA and lipid damage, and therefore your oocyte qualities improve. So this is a beautiful chart which says, you know, in this PCOS patient, you have different colors, green for the vitamins, vitamin-like nutrients, minerals and all. And just see, we need everything. And each factor, the oxidative stress, if you have, it's going to be taken care of, vitamin E, bioflavonoid, selenium and all. So everything is useful and is needed. If we come into our ART patients, we still cannot omit it, and endogenous sources are gametes and pre-implantation embryo. We have exogenous sources, the visible light, the centrifugation, the cryopreservation, the culture media, the oxygen concentration, and of course, the embryo transfer techniques. So these are all the endogenous which create the RO species. So many free radicals, not exempt even in the ART settings. How did they find out? When they put vitamin E, they found, you know, that the increased rates of blastocyst development and embryo protection. When they added vitamin C, they found there's a reduced DNA damage and increased rates of blastocyst development. And melatonin, when it was given orally, they found that it increased the number of fertilized eggs. The carnitine brought improvements in the blastocyst development rate by preventing the lipid peroxidation. As Sir mentioned, carnitine and CoQ are too important. So what can we do? We can just, what are the measures? Just go incubate for a very shorter time, lower the sperm concentration, the sperm preparation techniques, the density gradient can be used. You lower the oxidation, decrease the illumination. So many things that we can take care. And it is found that when you give these adjuvants, antioxidants, therapy to these patients of infertile, they were much, much better fertilization, the better quality of embryo, the better implantation, and therefore these pregnancy rates. Not only it ends over here, it's going to, you know, decrease the size of the ovarian follicle pool, and quality is the ovarian aging. So it's really helpful in these patients too. So many studies of them are there, but let's look into the Cochrane data. We have 50 trials and 6,510 women, and the rates were said, and they said subfertile women with expected live birth 20%, with oxidants it went to 26%, with clinical pregnancy rates from 22 to 27 to 33%, and miscarriages of 7%, but still between 4 to 7%. Also, there were adverse effects of miscarriage, maybe either similar or maybe increase, or multiple pregnancies and a few GI disturbances. So there were also other studies which said that adverse effects, not much, only maybe some incidents of DI side effects. Multiple pregnancy could be avoided by a single transfer. And of course, the safety data still well tolerated. So there were very low quality evidence to show that taking an antioxidant could benefit these subfertile women, but insufficient evidence to draw any certain conclusions as yet. But how do we take these micronutrients? Do we need to take twice a week, thrice a week, or can we take it every day? So look at this study which said that the risk of ovulatory infertility was reduced in the women who took a supplement of at least 3 times a week, and frequent use of when it was taken more than 6 tablets, the results were found to be much, much better. So I did think the supplementation needs to be taken on a routine basis, that is 1 tablet needs to be given every day. So infertility still remains to be an overwhelming problem amidst the high fertility rate of developing countries. Oxidative stress, a major contributor, especially in the unexplained and the Cochrane data, there is still low evidence and a significant improvement in fertility with the use of various micronutrients. Theoretically, antioxidants have the potential to combat the oxidative stress and a contributor to ART failures. Most of the RCTs are either inconclusive or low strength evidence. So conclusive guidelines are still required to regularize the use of antioxidants as oral supplements or as adjuvant in the culture medium of ART. So micronutrients still a key to good health, especially in the female infertility. But I think a successful engineering is all about understanding how things break and how things fail. Thank you so much for a very, very patient hearing.
Thank you so much, Ritu. It was a fantastic, informative talk. You cleared so many myths and misconceptions about the micronutrients in female infertility. We all talk about the role of antioxidants in male infertility, but in female infertility, you have cleared all the doubts. It was no doubt a fantastic talk on micronutrients in female infertility.
Thank you. Thank you so much, madam. And I think we can move on to the next presentation. And I'll just share the screen for introducing. It's again an honor to introduce a very, very dynamic, inspiring personality, Dr. Bhagyalakshmi Nayak, who is the head of Department of Gynaecology Oncology, AHP GIC Cuttack. She's a chairperson Oncology Committee from 2018 to 21, the governing council member ICOG, vice president AOGI in India, assistant editor Indian Journal of Gynaecology, a peer reviewer Indian Journal of Surgical Oncology Jogi, and of course lots and awards, Dr. Abha Singh Oration Award, and so many honors and credits and articles with her. So over to you, Bhagyalakshmi madam, for your presentation on nutrition in oncology.
Thank you so much, Team ICOG, Dr. Lakshmi, and all the stalwarts, and of course Ritu and Vidya for actually bringing out such a nice topic. I think nutrition is something which we really don't talk about it much. So I think it's really a nice effort, and I think it has made me also read so many things about nutrition in oncology, which is our day-to-day subject also. So please give me a moment to share my screen.
Yes, ma'am.
Okay, so is it visible?
Yes, madam.
Okay, so we'll be talking so much. We have been talking so much about nutrition, but I think my subject has been made very easy because, of course, the dynamics of reproduction and cancer and everything, the basis remains the same though. So I think my talk will be not very difficult for you all to understand. So let's go ahead. So I'll be dividing my talk into 2 parts. One would be about the preventive aspects of cancer, and the other would be after the person gets into cancer, what we are going to do. So I think let's go to the prevention first. I think we all will agree that prevention is always better than cure, and I don't think it's only for the participants, it's for all of us also to know how to change our lifestyles a bit so that we stay away from cancer, which is actually has become now a household name, because initially when we were in our early in our career, it was like if someone had cancer, everyone was so scared to talk about that. But now I think everyone in a family or a friend has a cancer. So I think people have got to know this more and more, and it is increasing. I think everyone will agree that the rates are increasing. So I think we have heard a lot about macronutrients and micronutrients, and they are the fundamental pieces in the structure and cellular function, as well as in the physiological regulation of the human, modulating the blood concentration of diverse hormones and activity of receptors and cellular signaling pathways. I think cancer is all about the cellular signaling pathways being changed and the receptors which are getting changed. So I think micronutrients have a huge role to play in that. So inappropriate consumption nutrients can favor the development of cancer as well as the progression of the disease, while adequate consumption or high doses can reduce the risk or contribute to the treatment. So this is from India to the world. We have a lot of medicinal plants now undergoing a lot of research in India by our Prime Minister, who is really giving us a lot of effort and a lot of entrepreneurship to do research on plants which are really cancer prevention, have a property for cancer prevention. So these are a huge important paper which has been produced, that all these plants which are available in India and should be included in our diet to prevent all these cancers, especially all gynecological cancers. So this is again yet another paper which has shown that plants in anti-cancer drug discovery from molecular mechanism to chemo prevention, and all these have been recently getting lot of propaganda to for cancer prevention. So an immunity booster, I think, is very, very important. This is for the prevention of the diseases and for prevention of all diseases. So we need to boost our immune system by whatever we do. Avoid alcohol and cigarettes, wash your hands, stay hydrated, take your vitamins, get enough sleep, eat fresh fruits and vegetables. I think these all have been talked and talked. So the most important thing which you all also know is in infertility is a molecule called selenium, which has a huge property of because it protects our cells from again the damage from the free radicals, supports our immune system, grows and keeps healthy muscles. So, and these are the fruits which are fruits and grains which are rich in selenium and should be included in our food. And of these important things are nuts, chia seeds, sunflower seeds, and all those we know about them, but then I think we have to just put in a practice and also counsel our patients about that. Then proteins, which are building blocks for the growth and development, helps in cell regeneration and boosts our immunity. They are all cereals and millets, pulses, legumes. I think millets are doing huge run now in all the markets in India. So I think millets are a very good source of protein and cereals. So high protein diet in the form of ragi, sprouts and soybeans should be included in a regular diet every day to make us healthy and prevent cancers. Vitamin D, we have already heard a lot about that. So all about vitamin D, we can get it from sun, and we can get it from vitamin D3 supplements. So this supports neuromuscular function and influences immune function and can be found in food supplements and exposure to sun, and it increases cell growth. So calcium and vitamin D work together to protect bones. Of course, we know that. But then it also has an important role to play in cancer prevention. And of course, vitamin B is important. It stimulates the immune system. I think our immune system has got a huge, immense role to play in cancer prevention, because as you know, every day some DNA aberrations are happening in our body, and because we are lucky, we have been able to abort them. But in case that malformation in the DNA persists, then we'll end up in cancer. So our immunity system needs to be boosted up so that it aborts all the malformations that happen in the DNA every now and then. The amount of exposures we take from the radiation, from the system where we are using fertilizers and all those things, so we are very prone to have cancer. So we need to take extra precautions so that our immunity system is strong enough and we are able to abort all the DNA misappropriations. So again, zinc is also an important thing which should be included regularly in your diet, because it also has anti-cancer properties. and including fluids and water. So this is also important because dehydration leaves you susceptible to illness and injury as your body is less able to fight off any challenges it faces. So stay hydrated, and that is important. So the importance of water in daily life, I think that's should not be overemphasized. So we need to drink lots of water before you feel thirsty, eat more fruits and vegetables that contain water, and of course remain hydrated. So I think herbal teas and kadas, which are again a product from India, carry a lot of antioxidants. So I think we in India are really fortunate to have all the medicinal plants available, in which we have all the anti-cancer properties as compared to the Western world. So we need to utilize it more and more. So again, coming to a very important thing is sleep pattern. So I think it's so important, and especially for our younger generation, that we should take care of our sleep pattern, and especially our women who are working in the IT sectors keep away from sleep for days and days together. So I think we need to take care of that, because that leads to a lot of stress and the low immunity status of the body. So again, coming back to the same thing, we need to look at a rainbow diet. So all colored vegetables and fruit should be on your platter, because red, as you see, helps cell renewal and prevents cancer. Green again prevents cancer. So I think these are all the things that we should look at and have them on our plates, instead of having all the red meat, which is really not very good for health. So I think we should take all the seasonal fruits and vegetables as are available during the summers, and that will really help us have a very good health and prevent cancers. So immunity system booster tips, we should all know: we should sleep well, manage our stress, eat healthy food, and stay active for optimal immune functioning, because as you know, obesity is an important factor for cancer, especially ovarian cancer and endometrial cancers. So I think you'll all agree with me that it is best to take a firm stand that prevention is better than cure, and so we'll all act on it. So then, coming to nutrition in cancer, if the woman already has that cancer, then what is going to happen? The nutrition needs of people with cancer vary from person to person. It's not a blanket approach. So eating well while being treated for cancer is very important. That will make the woman feel better. Keep up the strength and energy. We need strength and energy to fight the cancer, as well as the complications of the treatment. We need to eat well to maintain the weight and body store of nutrients. We better tolerate treatment-related side effects and lower the risk of infection, which the woman is very prone to during the cancer and during the chemotherapy cycles also, when the immunity is very low. And so that will ultimately help to heal and recover fast. So eating well means eating a variety of foods to get the nutrients needed to fight cancer. And these nutrients include proteins, fats, carbohydrates, water, vitamins, and minerals. So which is finally again a very good balanced diet. So factors of malnutrition in cancer patients is caused by: one is decreased food intake, which is common. This is due to the loss of appetite that commonly follows the disease as well as the treatment, and malabsorption due to various complications related to the disease and treatment again. And of course, it's the catabolism finally, which leads to wasteful metabolism. And so this all can happen due to the disease or due to the treatment. So how do proteins work? So people with cancer often need more protein than usual, because after surgery, chemotherapy, or radiation therapy, extra protein is usually needed to heal tissues and help fight infection. I think protein is the crux of all the healing mechanisms that occur in our body. So good sources of protein include fish, poultry, lean red meat, eggs, low-fat dairy products, nuts and nut butters, dried beans, peas, lentils, and soy foods. All this should be managed in a balanced diet in the body. So nutrition plays a crucial role in cancer care. It affects treatment tolerability, outcomes, and the quality of life. So we need to focus on nutrition is still lacking among healthcare providers. We don't think it's an important thing because of insufficient training in nutrition topics. And thanks Dr. Lakshmi for having taken up this topic, because we really have never had any specialized training about nutrition topics during our undergraduate and postgraduate careers also. So this received and the consequences of the disease and its treatment, such as anorexia, sarcopenia, cachexia, are often overlooked, underdiagnosed, and undertreated. So this is a very important aspect of cancer care, which we have yet to understand and manage and counsel our patients. And malignant disorders are one of the leading causes of morbidity and mortality worldwide. The incidence and prevalence is expected to increase in the coming decades. So we need to know more about it. So the major improvements in cancer treatment, surgery, systematic treatment, radiotherapy have been achieved over the past 20 years. There has been excellent improvements in all this. So resulting in improved rates of cure and prolonged survival in the palliative setting. The tolerability and outcome of multimodal approach depends on many factors, and one of the most important of which is nutrition. So all physicians and healthcare professionals, all of us must provide optimal nutrition as an integrated part of cancer treatment, which should start from the day the patient visits you. It's not after treatment. So the day the patient visits us, we have to assess about the nutritional status of the patient and counsel her accordingly. So identifying and understanding nutritional issues in oncology is a challenge because there is insufficient training in nutrition topics. A survey among oncologists also showed that there is a lack of awareness about understanding the consequences of cancer-associated weight loss. And so the prevalence of malnutrition was reported in several surveys as being up to 50% among hospitalized patients, and about 10% to 20% of all cancer mortality is directly related to malnutrition. So I think this is a very sorry figure to note. However, data show that appropriate nutrition through the use of comprehensive intervention may lead to improved treatment outcomes and prevention, early identification of patients at risk, accurate diagnosis, and personalized intervention and follow-up are cornerstones of the management of malnutrition and its consequences. So we as stakeholders play an important role about counseling of the nutrition of the patient and not only looking after the disease. So the basis of nutritional assessment is by anthropometric parameters, by the serum protein levels, and by immunologic tests. So the single most useful parameter, however, is the for nutritional status is change in weight. So this is the common complaint that the patient may also tell you that I am losing weight, which is an important way where you can assess about the nutrition. So the evaluation of nutritional status using the subjective global assessment divides the women into three groups. One is group A, which is normal nutrition. Group B is mild malnutrition, and group C is severe malnutrition. So if we group them, we can plan their management accordingly. So in the phases of surgery, we need support in chemotherapy, during radiation therapy, and even when there is palliative therapy, when we are not able to cure the patient in those phases also, that's very important to note about the nutritional status and manage. And we as healthcare professionals have to stand the test of time so that we help our patients choose better about what they need to eat. So coming to sarcopenia and cancer-associated cachexia and anorexia syndrome, patients with cancer are significant risk of developing this problem, and this is a multifactorial condition characterized by ongoing loss of skeletal muscle and or fat that cannot be fully reversed by conventional nutritional support. And sarcopenia and CACs are overlapping conditions that are often overlooked, underdiagnosed, and undertreated in clinical practice. However, the prevention, delay, treatment, or even reversal of sarcopenia are feasible. A multi-center study showed that 43% of hospitalized patients did not receive any nutritional support despite being diagnosed with malnutrition, and almost 40% of all hospitalized patients were malnourished. So when we take care of the patient as a patient and look at the disease only, our results are not going to be better if we are not looking after the nutritional status of the patient also. So early detection and treatment of malnutrition and its consequences are crucial for patients with cancer to maintain their physical function, mental well-being, and quality of life. So obese patients developing sarcopenia, it's difficult because they have a lot of fat. So if she's losing the muscle mass, it's difficult to see and diagnose. And even it is problematic in the geriatric population, especially older patients with cancer, where we take it for granted that it's due to the old age. So screening for nutritional problems, assessing muscle mass or function, and guided interventions related to nutrition and physical performance are therefore crucial in older patients with cancer who have been treated with surgery, systemic treatment, and radiotherapy. So practical nutritional guidance methodologies, we have various guidelines to help us do that. One is the European Society for Clinical Nutrition and Metabolism guidelines and the Global Leadership Initiative on Malnutrition GLIM criteria guidelines. So we need a diagnostic workup. This is a multidisciplinary tumor board, should always include dietitians and clinical nutritionists when the patient is first coming to us, when we are planning the treatment, whether she should go for surgery, go for radiation, or what should be the treatment, they should always include a dietitian at the outset. The concept that nutrition is an essential part of the cancer treatment and not an additional add-on service needs to be widely disseminated among healthcare professionals. And individual nutritional counseling is important. So there should be a registered nutritionist and dietitian who is concerned about the energy and protein needs, lifestyle eating. She should take a whole history of the patient and give an individualized plan for the nutrition. Appropriate supportive care during the treatment course is essential. All reversible symptoms such as nausea, vomiting, stomatitis, diarrhea, all these lead to nutritional problems. The patient and caregivers must understand the importance of the intervention and should be actively involved in the decision making. So I think caregivers should also be included in the problem, settling the problem. If oral or enteral feeding is not possible, parenteral nutrition may be an option in highly selected cases. So in palliative treatment for symptom relief, the purpose of the treatment in this situation is improvement of quality of life rather than prolonging survival. So more attention should therefore be given to patient preferences. Treatment options, expected benefit of the treatment and toxicity issues should be discussed, and individual nutritional counseling and adequate supportive care may contribute to increased quality of life and satisfaction among patients and caregivers. And this is in a palliative setting where we are not going to give cure to the patient. And when we are dealing with the end of life care, again, for patients who are dying, the goal is again maximum comfort. Enteral and parenteral nutrition do not provide benefits here. So short and limited hydration may be recommended only to avoid delirium or confusion. So this is a cyclical thing which has to go on and on. It has to be a regular nutritional screening, nutritional assessment, oral nutritional supplements and physical activity. If that doesn't work, then you move to artificial nutrition and follow up. And this should be periodical re-evaluation. So this is a continuous, ongoing and a dynamic process. You have to assess your patient throughout the treatment and thereafter. So now we have many herbs which have been used to treat disease for hundreds of years, mixed results, and many products are now available like in the pills, liquid extract, teas and ointments. So these are now coming up in a big way as cancer care treatments. And I think counseling is the very most important thing. We have to tell our patient that don't be afraid to try new foods, choose different plant-based foods, try to eat more fruits and vegetables every day in a variety of colors, try to stay at a healthy weight, that is also very important, and stay physically active, and limit or avoid red or processed meat, sugar, sweetened beverages, and processed foods. And I think you all know what are the side effects of all these processed meat and sugar. And energy for physical activity, we need lowering of treatment-related side effects, reducing the risk of depression and anxiety, improving sleep quality, aerobic exercise and resistance training and stretching, balance and breathing exercises may also be helpful. So chemotherapy and hormone therapy may cause different nutritional problems in the form of loss of appetite, nausea, vomiting, dry mouth, sores in the mouth, etc., etc. Similarly, radiation may also cause nausea, vomiting, bowel obstruction, colitis, and diarrhea. And surgery increases the body's need for nutrients and energy. So the body needs extra energy and nutrients to heal wounds, fight infection, recover from surgery. If the patient is malnourished before surgery, it may cause problems during recovery, such as poor healing and infection. Hence, nutrition care should begin before surgery. So anorexia treatments, and these are basic things which we all should advise our patients. They should eat foods that are high in protein, add extra protein and calories to food, eat high protein foods, sip only small amounts of liquids, drink milkshakes and smoothies, try new foods, eat small meals and healthy snacks, eat larger meals when they are rested, eat largest meal when hungriest, and be as active as possible so that you will have a good appetite. So all these things we have to explain to our patient. And if she has nausea, eat foods that are bland, soft and easy to digest. Eat dry foods such as crackers, breadsticks, etc. Eat foods that are easy on stomach. Eat dry toast or crackers. Eat foods and drinks liquids at room temperature. Slowly sip liquids. Suck on hard candies and stay away from food and drink with strong smells. So nutritional support may be given as a oral dietary therapy, enteral nutrition which is also called tube feeding, or parenteral nutrition, in which parenteral nutrition carries nutrients directly into the bloodstream and is given intravenously. So dietary supplements of nutritional therapy, one is vitamin C, probiotics, melatonin, oral glutamine, all this should be added in the diet. because vitamin C helps fight infection. Probiotics are needed, as you know, for the well-being of the gastrointestinal tract. And melatonin, I think it has a huge role even in infertility. So this is a hormone and is secreted from the pineal gland. And so small studies have shown that taking a melatonin supplement with chemotherapy and radiation therapy for treatment of solid tumors is helpful, because it also helps in reducing side effects of the treatment. Similarly, oral glutamine is an amino acid that is being studied for the treatment of diarrhea and mucositis. That is a common complication of treatment. And coming to enteral nutrition gives the patient nutrients in liquid form through a tube that is placed into the stomach or small intestine. The following types of feeding tubes may be used. One is a nasogastric tube. The other could be a gastrostomy tube or a jejunostomy tube, in which the tube is inserted directly into the small intestine through an opening made on the outside of the abdomen. And this is usually used for long-term enteral feeding or for patients who cannot use a tube in the nose and throat. So this is conditions usually happens in ovarian cancer patients in where they present in advanced stages with advanced intestinal obstruction. And enteral nutrition is indicated actually or anticipated inability to meet at least 50% of the need, contributes to quality and length of life in meaningful way, can improve the tolerance to treat and our ultimate outcome, and patient wants it. Patient should want it. A functioning gut should be there and is not contraindicated if there is obstruction or gastroparesis. So it may be able to bypass with a J tube, or is there hypomotility of the small intestine as well. So we have to consider many things before you plan for enteral nutrition for your patient. Then coming to parenteral nutrition carries nutrients directly into the bloodstream. These nutrients include proteins, fats, vitamins, and minerals, and they can be planned. The amount of the protein, fat, vitamins, and minerals can again be personalized according to the need of the patient. The catheter may be placed into a vein in the chest or in the arm, and usually a central venous access catheter is placed beneath the skin and into a large vein in the upper chest, or the catheter is put in a place by a surgeon, and this type of catheter is used for long-term parenteral feeding. So total parenteral nutrition, otherwise called TPN, the advantages is that when a patient is not able to tolerate orally, it would help in increase in weight, improved hydration, reduction of vitamin deficiencies. But there are complications which may be catheter related or metabolic or infections. So is usually given in a hospital setting, but the indications have to be taken very carefully so that the patient has a good performance status with temporary inability, prolonged postoperative IBS or gastrointestinal complication. So it usually happens in ovarian cancer surgeries where large loops of the intestine may be required to be removed, and the patient is put on TPN for some time before she is able to resume oral diet. And the most importantly, these are the two important things, magnesium and vitamin B12, which have been seen that even if without weight loss, there may be severe deficiency and contribute to significant morbidity in cancer patients. So just to summarize what all have told, nutrition plays a crucial role for patients with cancer and is maximum in ovarian cancer. Nutritional status of onco patients should be assessed, and this has to be done throughout the treatment and post-treatment. Nutritional problems are often under-prioritized, under-diagnosed, and under-treated. So we have to be very careful about this point, because the results of your treatment will finally depend upon the nutritional status of your patient. And this affects treatment outcomes and the quality of life. And so focusing on the practical aspects of the daily routine will help improve patient care. So I thank everyone for giving me this opportunity to discuss about a very tricky subject, which is nutrition in oncology, which is never ever discussed with the patient. And only when the patient becomes totally malnourished, then we start talking about it, start talking about TPN and all those things. So I think it would be an eye-opener for all of us to talk with the patient right from the beginning of the treatment when she comes to us about nutritional issues. Thank you very much. Thank you, Dr. Ritu and team, for giving me this opportunity.
Thank you so much, madam. I think that was fantastic and a comprehensive, very crisp, and so many points that you brought out, madam. 10 to 20% of cancer mortality, just imagine, is just because of nutrition. And I think the special counseling sessions, we're more focused to the medicines. And sometimes I think they come up with nausea, vomiting, we just push them in more medications, in spite of, not even realizing that there is some nutrient deficit which is going on. And I think we miss on them. So part of an oncologist should be a counselor. A counselor should be sitting always in your clinic and be, and I think the patients will be really happy. They are already depressed. If we give them things, they sometimes ask us, kya khana hai, kya nahi hai, and we are just focused on medicine and we push them out. So I think that was a very well taken up point. And if we go on and Dr. Lakshmi ma'am keeps giving us these sessions, I think we're going to explore with so many things, so many herbs and everything. And all of us are going to come up with researches, madam. So it was really, really, such an enlightening talk. Thank you so much once again, madam. And I'll just peep into the chat box if there are any questions. I think it was so elaborate and there was anything left out there. So thank you, madam, once again for giving us your time. And yeah, thank you so much, madam. So I'll just share the screen to introduce the next speaker. So it's a privilege for me to introduce a teacher par excellence, a very humble and a loving personality, and that's Professor Dr. Revati Gynaecology. So she is the former director, IOG Chennai, Vice President, FOGSI South Zone 2016, President, TNFOG, Founder, Secretary and past President, Madurai Obstetric Gynaec Society, Founder, President, IMS Madurai Chapter, President, Madurai Chapter of Tapisar, a recipient of FOGSI Dr. Durusha Community Services Award, recipient of Lifetime Achievement Award, IMA Madurai, author of FOGSI Focus on Amniotic Fluid A to Z, contributed so many chapters in the FOGSI Focus issues. And madam, we would like to have even one of your chapters in our upcoming FOGSI Focus on micronutrients and food fortification, and Pride of FOGSI Award in November 2019 at Mumbai. So many awards and honors to her credit. And thank you so much, madam, for being here with us. And over to you for your presentation on nutrition in menopause.
Can you see the slides?
Yes, madam. You can make it on a slideshow, madam.
Oh, yeah. Right?
Yes, madam.
Okay.
Perfect.
Thank you very much, Dr. Ritu, for the kind introduction. And really, I appreciate and congratulate Dr. Lakshmi and Dr. Vidya for making all of us aware that there are so many aspects of nutrition to discuss on. Really great. Now coming to my topic, everyone wants to swing forth and back like this, even after the age of 70, isn't it? So how is it possible? So to be active, even at menopause, you have to focus on the lifestyle, more importantly on nutrition. Nutrition is a key component for successful aging and quality of life. A healthy, balanced diet plays a significant part in the management of menopausal symptoms too. Since the risk of cardiovascular disease, diabetes, and weight gain increase after the menopause, it is critical to assist women in selecting a diet high in nutrients but low in caloric density. Women in their 40s and above face several obstacles, including hormonal fluctuations, which cause weight gain, loss of bone and muscle mass, and digestive issues too. However, to begin a healthy menopausal transition, proper nutrition is very, very important. As you know, sarcopenia, changes in bone density, digestive system, and renal system, all these things are related to age, in which again, nutrition has a great impact. Now, just let us see the systems one by one. Digestive system. As in when we age, there is a decrease in the saliva production, which you call as xerostomia, changes in the dentition, which alters the ability to chew and may lead to changes in the food choices. There is a decrease in the gastric acid secretion that can limit the absorption of iron as well as vitamin B12. Peristalsis is lower and constipation may be an issue because fluid intake is decreased. Appetite and thirst dysregulation also occur, leading on to early satiety and a blunted thirst mechanism. Sensory changes also affect the appetite in so many ways. Like when there is a vision loss, it makes it shopping, preparing food, and even eating more difficult. Diminished taste and smell also take away the appeal to many foods. Women need about 200 calories lesser per day in their 50s than they needed in the 30s and 40s. So if the requirement is 2000 calories per day in earlier, now it is reduced to 1800. It is sufficient. But it will be difficult for some to meet daily requirement of micronutrients, which we are talking left and right about this micronutrients needs, but that may be reduced with the reduced caloric intake. To combat this, multivitamin supplements may be recommended. Obesity, malnutrition, undernutrition, osteoporosis, cardiovascular disease, all those things right from head to foot, all these problems in midlife women are nutrition related. The foods recommended to get this macro and micronutrients are, as all of us very well know, meat, fish, and egg for proteins, rice, bread, pasta, like for carbohydrates, olive oil, oily fish, nuts, and dried fruit for fats, fruits and vegetables for vitamins and fibers. Now, decreased skeletal mass in the old age, there is a decrease in the storage in the muscle protein also. Now, protein-rich food with curd and milk should be included. Due to decrease in the appetite and poor digestion, old people consume less protein, which can lead on to edema, anemia, low resistance to infection. Why this is not moving? Yeah. Emphasis should be placed on reducing the intake of saturated fats. You have to reduce the saturated fats and choose mono or polyunsaturated fat sources. Now, sufficient intake of omega-3 fatty acid may help in conditions like hair loss, impairment of vision, improper digestion, painful joints, mental depression, and all. Incorporate the plant-based omega-3 fatty acids regularly by taking flax seeds, canola oil, walnuts, and soya beans. As to avoid animal fats, minimize the oils also. And it has been found that in Women Health Initiative, perimenopausal women following a reduced fat diet, they scored significantly lower on BMS subscale compared to those whose diets derived approximately 30% of energy from fat. Now, to boost your fiber intake, increasing the dietary fiber may be useful in the treatment of constipation, glucose intolerance, lipid disorders, and obesity, as well as preventing diverticular diseases and colonic carcinoma. Make sure to consume a fair amount of fiber each day, as it will not only make you feel full, but also it will not lead to any extra calorie intake. Lycopene, a lipid-soluble carotenoid, has been shown in studies to guard against bone damage. We are all the time worried about the bone problem only after menopause. Now, oxidative stress is associated with loss of bone mass, and antioxidants can prevent this loss. Tomatoes and tomato derivatives are high in lycopene, which is a potent antioxidant. Tomato-based food products have health-promoting as well as disease-preventing effects. Watermelon, pink grapefruit, and carrot are good dietary sources of lycopene. Dietary supplementary phytoestrogens modestly improve the hot flushes and vaginal dryness. The bean of soy plant is used in both foods as well as phytotherapeutic supplements. Isoflavones or black cohosh relieve the vasomotor symptoms. In a Cochrane review, which evaluated 16 RCTs, they have shown the effectiveness of black cohosh in reducing the menopausal symptoms. And ACOG 2015 clinical guidelines for managing menopausal symptoms also concluded that herbal dietary supplements like black cohosh is efficacious for the treatment of vasomotor symptoms. Micronutrients should be from 2 to 3 servings of fruits and vegetables. Milk and milk products for calcium 1000 to 1500 milligrams of calcium per day is recommended. Dark green vegetables should be included at least once a day to ensure required amount of folic acid, zinc, calcium, as well as iron. About calcium, we heard a lot about the calcium intake by Dr. Meeta yesterday. And to stress a little more about this role of calcium in menopause, during menopause, a woman's calcium requirement rises. Why? The calcium absorption performance as well as the renal conservation both are estrogen dependent. So when the estrogen is deficient, this also will deteriorate. So the requirement increases. Postmenopausal women should consume at least 1200 milligrams of calcium per day. And to reap the nutritional benefits of calcium, obviously, you must have adequate vitamin D status also. Calcium-rich food are obviously spinach, moringa leaves, that is this drumstick leaves, brinjal, milk and milk products, and broccoli. Sufficient calcium intake has been shown to prevent bone deterioration and fractures in peri as well as postmenopausal women. And surprisingly, it has been known that calcium enhances the bone protective effect of the MHG also. Assess the total calcium intake from the dietary sources. You cannot just take their prescribed calcium. Assess how much they are taking from diet, and if needed, supplements are used to correct the deficient balance. The intake should exceed 800 milligram per day. Now, we are more worried about the cardiovascular event as well as the calculi, but usually with the recommended dose of calcium, these are not met with. And prevention of kidney stones is possible if calcium is taken in the prescribed dose with sufficient fluids, as well as preferably in the citrate form. Elderly people are at risk for vitamin D deficiency due to the decrease in exposure to sunlight or decrease in the renal mass. Vitamin C may be protective against cataract at an intake of 150 to 250 milligram per day. Stress, smoking, and medication may increase the vitamin C requirement, so reduce stress. Vitamin E is a potent nutrient for reducing the decline in cellular immunity that occur in the elderly. Requirement of B6 again are increasing elderly. Liver dysfunction is again a risk factor for deficiency of vitamin B6. And vitamin D deficiency, it is very, very important to take care in the elderly because the skin becomes less effective as a source as the age advances, once you become 50 plus. At the same time, the dietary intake is also low exposure to sun, clothing, sunscreen, window glass, and all pollution. All these things reduce the amount that is produced. And the best time is the sunlight exposure between 11 a.m. to 2 p.m. Now, obviously, vitamin D deficiency, if detected, to be treated, managed with supplementation of polycalciferol, either oral or injection, and maintenance dose to be given. Vitamin E is a fat-soluble vitamin, and it has many times you have seen menopausal symptoms, right and left, they prescribe Evion or vitamin E or something like that. But actually speaking, it has very marginal efficacy in reducing the heart flushes. If at all, average reduction of 1 heart flush per day may reduce the frequency of vasomotor symptom. 800 to 1000 internal units per day in divided doses is to be taken with food. Now, another important thing is about the collagen. It has got a lot of benefits. It improves the skin health. It may help slow aging of the skin, helps relieve the joint pain. It has been shown to reduce inflammation, could prevent the bone loss because it increases the BMD, could boost the muscle mass because it increases the muscle growth as well as strength. It promotes the heart health because it reduces the risk factors associated with atherosclerosis. Hair and nails, it stimulates the hair growth, may prevent brittleness. Brain health, again, it improves the mood and reduces the symptoms of anxiety. Weight loss, again, faster metabolism and promote the weight loss. Now, where to get this collagen? There are several foods which contain collagen, both in vegetarian as well as non-veg. The most abundant amino acid in collagen are glycine, lysine, and proline. And plant-based foods high in all these three include soy products like tofu, and soy protein, black beans, kidney beans, legumes, seeds, pumpkin seeds, easily available, squash, sunflower seeds, and nuts like pista, peanut, and cashew. In non-veg, chicken skin, pork skin, and fish. And menopause brain fog. Many women feel forgetful and having a general brain fog that makes it hard to concentrate. There are 8 top foods to beat the menopause brain fog, like green leafy vegetables, fatty fish, berries, walnuts, flax seeds, avocados, broccoli, and turmeric. Green leafy vegetables like spinach, collard greens, and mustard greens are high in lutein and zeaxanthin, which can help protect our eyesight as well as memory as we get older. A 5-year survey of 950 older adults showed that those who consumed at least 2 portions of dark leafy greens per day had a slower loss in the brain activity than those who did not consume any leafy green at all. Fatty fish such as salmon, mackerel, sardines, and tuna are high in omega-3 fatty acid. And in cases of mild Alzheimer's disease and severe depression, this has a lot of beneficial effect in improving the brain control. As an alternative to seafood, DHA supplements are a better source of brain-boosting omega-3 fatty acids. Berries such as strawberry, blackberry, blueberries, all these contain antioxidants that may aid in weight loss, disease prevention, and inflammation. Now, for memory, berries, walnuts, and flax seeds are very, very essential. The berries are abundant in anthocyanins, which have been shown to successfully counteract the age-related deficiency in specific aspects of working memory. Walnuts give a decent supply of alpha-linoleic acid, ALA, and omega-3 fat, as well as other brainy healthy compounds. Now, it has found that those who consume 15% of their calories from walnuts postpone the start of cognitive loss. And walnuts can actually enhance nerve connectivity in the brain, while also reduces the inflammation and stimulates the formation of new neuron pathways. I'm sure after going home, everyone will start taking walnuts. Flax seeds are the best plant-based source of antioxidants, and they are high in ALA, the omega-3 fat and precursor of DHA, and they consume ground flaxseed rather than entire flaxseed because it is easy to digest. Flaxseed oil has been found to increase the levels of neurotransmitters in the brain. Avocado's intake has been found to increase the density of lutein in the brain. Memory, concentration, and problem-solving abilities were also enhanced in the avocado community. Broccoli is high in ALA, vitamin K, and choline, and broccoli will help keep the mind sharp. Choline helps to improve the adult brain function and prevent the age-related memory loss and have neuroprotective implications in degenerative brain disorders such as Alzheimer's. Turmeric, an Indian spice distinguished by its bright yellow-orange color, the combining this curcumin, the main content of the turmeric, with black pepper, which includes the element piperin, is associated with a great improvement in curcumin bioavailability. I still remember my grandmother who used to take a cup of milk with the freshly crushed black pepper and a little of turmeric powder, of course, without sugar. It is very, very healthy. And it can enhance memory, focus, and concentration and cognition in elderly. Now, insomnia affects 61% of postmenopausal women. Can we avoid that? Yes. Avoid eating large meals before bedtime. Avoid spicy and acidic foods, which may cause hot flushes. Thereby, it may disturb your sleep also. And avoid caffeine, alcohol, and nicotine before food. Of course, don't wear heavy clothing and try deep breathing exercise and yoga also. Increased abdominal visceral fat is a part of menopause. One should avoid trans fatty acids as they are more dangerous than saturated fats. Now, avoid biscuits prepared with trans fatty acids. Here, I remember Lakshmi's words, you have to see the label and see what type of fatty acid is included in that particular product. A 2% rise in trans fat energy consumption has been linked to a 23% increase in the incidence of heart disease. Now, repeated heating and frying led to an increase in the trans fat content. Now, FSSAI clearly states that oil should not be reused more than 2 to 3 times. Coconut oil is rich in medium-chain triglycerides that are largely used by the body for production of energy. Hence, a chance for it to be stored in our body is less likely, and it is exceptional at helping people lose abdominal fat. Oats contains beta-glucan, which is a soluble fiber that helps bring down the cholesterol level, especially LDL in the body. Now, what about sarcopenia? Can you prevent or treat it with the diet modification? Yes. Sarcopenia is a muscle loss associated with aging, and it affects around 30% of the elderly, and proteins play an important role in sarcopenia. Aging is associated with the reduced ability to stimulate the skeletal muscle protein synthesis in response to feeding, insulin, and resistance exercise. To maximize the muscle protein synthesis, a dietary plan should include 25 to 30 grams of high-quality protein per meal. Whey protein improves muscle mass and insulin sensitivity in elderly. Whey protein has also been shown to enhance the lean muscle mass. And it minimizes the sarcopenia by stimulating the postprandial protein synthesis and limiting the body protein loss. It contains abundant levels of leucine, and it is the most potent dietary strategy to increase the muscle protein synthesis. Physical activity, specifically the resistance training, combined with consumption of whey protein, has additional benefits on muscle protein synthesis. Ingesting 10 to 20 grams of whey protein after activity can improve the protein synthesis in elderly, presumably due to the high levels and efficient absorption of EAA and leucine. Never forget about water. It is more essential for old people as it is for young also. It is essential for adequate renal function as well as to combat constipation. Dehydration can result in mental confusion, headache, and mental instability. So be sure to hydrate. Even when you don't feel thirsty, take adequate amount of water, because water keeps your energy levels up. Also, it makes your skin smooth and make you look very young. And it's quite interesting to note that Indian diet is menopause friendly. Fennel seeds, cardamom, garlic, moringa leaves, it's all used in day-to-day diet, which is very, very friendly with menopause. Fennel seeds is used to combat the hot flushes because of its estrogenic effect. So also cardamom to mitigate the menopausal symptoms. Garlic improves the bone and joint health and muscle health. Moringa leaves to mitigate the menopausal symptoms as well as the overall health. And evening primrose oil, vitamin E, sage, flaxseed, soy, and vinegar are used as remedies for hot flushes too. Now, when I talk about what are all the things to take, what not to, like tea, coffee. Avoid more than 200 milligram per day of coffee. Limit intake of tea and coffee to 3 cups a day. And you know that 1 cup of brewed coffee is equal to 120 milligram of caffeine, and 1 cup of instant coffee or tea is equal to 65 milligram of caffeine. Without knowing all these things, we go for a brew, this, that, and all. And one thing is that I have stopped taking tea or coffee for the past 8 years, of course, without sugar. It is very easy to follow that. Now, consume minimum of 500 to 600 ml of milk or curds with low fat to build on calcium bank in the bones. Support it with a lot of vitamin C rich fruits and vegetables to favor calcium absorption. Say no to sugar. Watch your sugar intake. Start with taking lesser amount of sugar. It is not easy to abruptly stop it. Slowly reduce it, and ultimately you can totally stop it. Of course, carbonated soft drinks also contribute a huge percentage of sugar intake, resulting in massive weight gain. So should be avoided. And crash diet, not at all good, because in the long run, it is going to really damage. There will be a rebound weight gain. Actually, the weight maintenance is a balance between the calorie intake and calorie expenditure. Don't reduce the calorie intake. Instead, go for a calorie expenditure by way of exercise. Now, after 40, turn the plate. That is thing that is told in Tamil also. Okay. So earlier, you used to take the rice on our end and vegetables on the other end, more of rice, less of vegetables. But after 40, minimize the rice intake and maximize the vegetables. Now, behavioral modification strategies also must be followed. You have a diary to self-monitor. And stimulus control, how? Eating about the same time each day. Now, all these things, please note, because many of us, we doctors, do not follow it at all. And avoid distraction while eating. Use small plates for food. Avoid second helping unless it is fruits or vegetables. Don't go for shopping when you are hungry. You know very well that when you are hungry, when you go for malls, how much you eat, you never know, and how much of calories you increase also, you never count. And eating before getting very hungry, that again, otherwise once you are very hungry, you don't know how much you eat. And chew the food for ample amount of time. Eat with your eyes, nose, mouth. Okay. Eating while distracted, working, watching TV, scrolling on the phone. This is the thing many a times you do. Eating and watching the phone. All these things lead to weight gain. And sitting at a table and using a plate for your food is recommended rather than eating from the out of a package or snack bag. Learn to eat mindfully. Mindful eating involves focusing on what you are eating and how it makes you feel. Meal timing is also very important, because people with irregular meal timings are prone to become obese. When you have irregular meal timings, your body feels confused and starts saving the fat for the rainy seasons. Starvation and skipping meals will bring back the stronger cravings and leads to binge eating. I have seen, now Ramjan also has come. Now, even anywhere, after breaking their fast, they tend to take high-fat prasadams, Purnam poli, vadas, this, that, and all. Ultimately, they get converted to fat only. And avoid binge eating. Now, we are talking a lot about fasting yesterday. Now, Bhagavad Gita itself says that when you don't eat between meals, that itself is equivalent to upavas. That is very, very important. If at all you feel hungry between meals, consider having some fresh fruits. Now, again, make sure that you don't pair it up. Don't pair the fresh fruits with something like custard or ice cream, which will increase again your calories. And if you avoid binge eating, you'll feel hungry and enjoy your meals also. So to conclude, dear friends, tips on healthy eating in midlife: eat an enjoyable and varied diet, watch your weight and stay active, eat plenty of fruit and vegetables, opt for healthier fats, plenty of fiber, reduce your salt, eat calcium-rich food, boost your B vitamins through varied diet, keep well hydrated, look after your teeth, very, very important. A little sunshine is very good. Go easy on alcohol and don't smoke. Get enough sleep. Keep your brain stimulated. Use it or lose it. Keep active. That is very, very important. And last word is that remember, supplements and functional foods, they don't replace a healthy diet. So very important is use the nutrition. Good nutrition helps you to age gracefully and face the menopause peacefully. Now look at this picture. How many of you see the old age phase or a young phase? And of course, getting old is inevitable, but still, even after getting old, you can still remain young physically and mentally, provided you take care of your nutrition. Thank you very much.
Thank you so much, Revati madam. A real illuminating talk. We learned so much. I think so many of the things we were not aware of. Menopause, a stage of neglect that we do. But I think, if we lovingly take care of all these women, so many things, madam, today went into our heads, like fiber, how much to take, simple thing, walnuts, berries, flax seeds, broccoli, oats. She wouldn't even forget anything. She looked beautiful. She looked so fresh. I think it's so rejuvenating. So many things you've told us, and do a mindful eating. And I think, there has to be a ready reckoner for them. And we should all put it in our clinics. And I think Lakshmi madam, our committee will take this initiative and we'll make ready reckoners for menopause and all these, so that it's on our tables and we don't have to think, ab ye karo, you take this, itna khana, and they'll be all happy. And I think they'll keep coming to us also, and we'll also be very happy with them. Thank you so much, Revati madam, for that very knowledge thing that we had. We had so much of learning today. Thank you so much, madam.
Thank you, thank you, thank you.
And I think if there are no questions, Lakshmi madam, can we proceed to the second session?
Yeah, please start. Yes.
So now we proceed to our second session, and that's, I think, the most awaited one. So for this, I would like to invite our panelist and then our expert for this. So inviting our panelist. Panelist, Dr. Asha Jain, who is the Director, SMSA Hospital, Raipur. She is the Zonal Chair for FOGSI Food and Drug Medical Surgical Committee of the West Zone. And she is the immediate past President, Raipur OBGYN Society, with fields of interest into saving uterus, fetal medicine, obstetric and critical care, and preventive oncology and colposcopy. Welcome to you, Dr. Asha. Then we have Dr. Anupama Bahadur, who is Professor and Unit Head Department of OBGYN, AIMS Rishikesh. She heads the robotic surgery. She is the Vice Dean, Social Outreach Program. She has been the Secretary of Indian Fertility Society and the Treasurer for the same from 21 to 23, the Vice President of NMO and areas of interest of reproductive medicine and infertility. Welcome, Dr. Anupama. Dr. Jyoti GS, who is the Professor and Unit Chief Department of Obstetrics and Gynaecology, Ramaiah Medical College and Hospitals, Bangalore. She's been the Vice President of Bangalore Obstetric Gynec Society 21-22 and is also got a Limca Award for the Nutrition Advice in Pregnancy organized by Zydus. And she has been so many publications and all to her credit. And of course, she is a member of our Food and Drug Committee also, and we are privileged to have her. Welcome, Dr. Jyoti.
Thank you, Dr. Ritu.
Dr. Manoj Chalani, who is the chairperson of FOGSI Medical Disorders and Pregnancy. He is a president, Raipur Menopause Society, and president-elect CG ISAR. He has been the founder, president, IFS Chhattisgarh chapter, and has also organized a lot of conferences and written so many publications to his credit. Welcome, Dr. Manoj.
Thank you. Thank you.
Dr. Jyoti Sharma, who holds a master's in PhD in food and nutrition and master degree into public health research, more than 20 years of experience and as academic and research nutritionist and public health professional at IIPH Delhi. She's involved into a lot of teaching, training, and researches, and has been a faculty of those, and has been faculty for the lead of public health and nutrition, coordinates e-learning postgraduate courses of maternal and child health program with area of expertise into maternal, child health, and nutrition. A pleasure to have you, Dr. Jyoti. Then we have Dr. Archana Sharma, who is consultant IVF and laparoscopic surgeon, scientific and clinical director, Ganesh Hospital and Test Tube Baby Center, Ghaziabad. She was a past president and chairperson and secretary of Ghaziabad Obstetric Gynec Society, the North Zone coordinator for Food and Drug Committee, and the organizing secretary of many state as well as national conferences with field of interest into fertility, enhancing laparoscopy, ultrasound, ART, and of course now would be nutrition too. So welcome, Dr. Jyoti Sharma. And also we have as an expert, Dr. Vidya Thobi Madam, Professor and Head of Department of Obstetric Gynaecology, Alameen Medical College, Vijayapur, Kasoga President-elect 2022, the chairperson. She has been of the Food and Drug Committee, and the Best Committee Award she got as Meru Narahan Soti Award in 2021, the ICOG Governing Council member, so many papers, so many conferences and has got so many credits to her honor. And it's always a pleasure to work with her. So welcome to you, Vidya Madam. And I think we can move on to the panel. Yeah. So the panel is nutrition across the life cycle of women. So welcome all esteemed panelists. And I think we had this 3-day ICOG nutrition course. So the first question that I bring to Dr. Asha, what is nutrition?
Thank you, Dr. Ritu. I think this is the most basic but most important question that we need to understand.
Yes.
So I've taken a definition. Nutrition is the sum total of the processes involved in the taking in and the utilization of food substances by which growth, repair, and maintenance of the body are accomplished. It involves ingestion, digestion, absorption, and assimilation. Nutrients are stored by the body in various forms and drawn upon when the food intake is not sufficient. So basically, nutrition is everything food and everything body. It is the food that we take that actually makes up our body. And the process of converting that food into our body, which is functional, is the process of nutrition.
Yes. So I think it's a basic human need. It's a prerequisite of life. And WHO says nutrition is the intake of food considered in relation to the body's dietary needs. So we've spoken so much, but let's know what is a good nutrition. It's something which is adequate, which is well balanced, and it's combined with a regular physical activity. And I think that's the cornerstone of our health. And we've learned so much that if you don't take care, it's going to reduce immunity. So we need to move on to immunological compromised patients, to cancer patients, and all these things. So thank you, Dr. Asha, for highlighting, because we're coming to an end. So just continue to concise exactly what we need to know about nutrition. Dr. Anupama, so many diets. When do you say it's a healthy diet? I wanted to know, am I taking a healthy diet? Am I on the right lines? So it's over to you, Anupama.
Good evening, ma'am. Ma'am, thank you for having me on board. So I think, ma'am, you are having a healthy diet because you look so beautiful and young. Okay. So having fruits, vegetables, legumes like lentils, beans, then including nuts and whole grains in the diet, switching from, white rice to brown rice, oats, millets, unprocessed maize, all that constitutes a healthy diet. For a daily recommendation, they say that an adult should include at least 2 cups of fruits, that is 4 servings, and 2.5 cups of vegetables, 5 servings in a day. If somebody is consuming red meat, then it should be eaten 1 to 2 times per week, and poultry 2 to 3 times a week. And at least, having 400 grams of fresh fruits and vegetables in the diet. But fresh fruits and vegetables, they do not include potatoes, sweet potatoes, and other starchy roots. They are not classified as fruits and vegetables. As far as the total energy intake from free sugars is concerned, it should be around 12 level spoons, which is equivalent to 50 grams. Yeah. And the total energy intake from the fats should be less than 30%. Unsaturated fats, as ma'am has already mentioned in her lecture, that is found in fish, fatty meat, butter, palm, coconut oil and all, that one is preferable to saturated fats. So, found in fish, avocado, nuts and sunflower olive oil, that is preferred to the saturated fats, which is found in fatty meat, butter, palm, coconut milk, etc. As far as salt is concerned, it should be less than 5 grams per day, that is 1 teaspoon. And we should use iodized salt. This is according to WHO 2019.
Yeah, thank you so much, Anupama, that you've given us so much of briefing, and we really need to take care. So many fruits, so many things should be with us. And another thing, I think, we have to take care of 2 pyramids. One is a healthy food pyramid, and the basis of the vegetables, and then comes the fruits, then come the seed and nuts, and then the eggs and fish and fat-free dairy, and then comes the sweet processed foods. And the second pyramid, I think, is this: what we really need to take daily, what is optional, and what we can take it as weekly. So daily is the broad base that we have fruit, vegetable, whole grains, olive, legumes, all the water and herbal infusions, the milk, physical activity needs to be added. And then is an optional that we have with the low fat and reduced fat diets. And we have weekly basis that we can have sweets. So just see, you know, what we need to note is out of all the vegetables and all, potato goes up. You know, so we need to consume less of potato, and that falls into a weekly rather than a daily one. So I think the small things into two pyramids, I think, and we really need to take care. So thank you, Anupama, for taking us through all this, that we need to have a healthy diet. But apart from healthy, you know, they always say, take a well-balanced diet, take a well-balanced diet. Jyoti, what is this well-balanced diet? She said healthy. Now you are to tell us, what is this well-balanced diet?
Well-balanced diet is having adequate amount of proteins, carbohydrates, and fats. And why we take well-balanced diet is from top to bottom, it is helping us. It is supporting us with a strong immune system. Like, for example, if there is any infection, when we consume well-balanced diet, it defends against whatever the infection, against bacteria, virus, or whatever, boosting a very good antibody response. And also at the mental level, it will increase the mental spirit, moods of the individual, the mental spirit, by taking good food, like somebody said, healthy fats, proteins, complex carbohydrates, and it reduces the risk of acquiring these NCDs, diabetes, hypertension, cardiovascular problems, coronary artery disease, thyroids. And by its antioxidant effects, it will reduce the effects of aging, anti-aging properties, along with this green leafy vegetables, chocolates, and all when we consume. And for muscles, for bones, for digestive system, for teeth, skin, eyes, and to live long, we need to consume and good fat. Bad fats, like somebody said, saturated fats, trans fat, they damage the brain tissue, whereas good ones, olive oil, fish oil, nuts, and all, they reduce the rates of dementia. Eating healthy, keeping good health, all those things, it helps. And so it is very important to have a good balance.
Thank you, Jyoti. I think that was a brilliant message that you gave us, the desire to live long. So if we have a desire to live long, we need to take a well-balanced diet, because if you consume this throughout the life course, it helps you to prevent malnutrition, so many, and we are really afraid of the non-communicable diseases. So I think if you've taken us so well that we need to insist to take a well-balanced diet to live long and to be free of communicable diseases. But we are so much being nagged, you know, of the mental health. You know, kya khao, it should be good. Really, does it? I have a stomach upset every time. What is it? So is it something correlating, Dr. Manoj? Mental health, diet, nutrition, gut health, are they something connected?
Yeah, definitely. I mean, diet and mental health and gut are interrelated with each other. If there's a deficiency of vitamins, for instance, if there's a deficiency of B1, that will lead to poor concentration, attention. Then the depression can also be because of the deficiency of vitamin B3. And then there may be poor memory or stress, which may be because of vitamin B5. And like if there's a deficiency of vitamin B12, we have seen the confusion, there's a poor memory, psychosis is there. Again, depression can be because of lack of vitamin C. Then folic acid, we are aware that anxiety, depression, this can be because of deficiency in folic acid. Magnesium does play a very, very important role in cases of irritability, insomnia, depression again. Then selenium forms a very, very important part. And now zinc also plays a very important role as far as confusion. Then there's a depression, loss of appetite. So all these things play a very, very important role. Like there's serotonin, we know the deficiencies there, or dopamine deficiencies there, or omega-3 deficiencies there. So all these things will lead to a major depression. Magnesium difficulty will lead to a major depression. Then in case of bipolar disorder, so vitamin B again in this case, folic acid deficiency, and omega-3 again in this case is schizophrenia. In fact, we have seen that because there's a glycine deficiency or omega-3 deficiency. So all these things, we should understand that diet really plays a very, very important role, and in turn the GI also. So take our food should be like full of these things, vitamins and all.
Yes.
So that plays an important role.
Yeah. So I wanted Vidya Madam also, her comments for it and her expertise, but I think she's not able to join us. So if you see, the gut and brain are in constant bidirectional communication, and that's to the vagus nerve. And the bacteria in the gut digest the food you eat and create certain neurotransmitters. And that's very, very important. So the lining of our gut contains an independent nervous system, which is called as an enteric nervous system. So there have been certain studies, in the mice and everything, changes in the microbiome change their behaviors too. So that is a beautiful connection that the mental health is related to our gut also. Dr. Jyoti, you being into research, into so many of these as a faculty and so many into it, so many diets, we have Atkins diet, we have a Mediterranean diet, we have a Western, a ketogenic diet and all. So I don't know, so many designer diets. Is it a hype or it's really healthy?
Thank you very much for opportunity and very good evening, everybody. When it comes to designer diets, and the whole thing about designer diets actually falls on women all the time. Women are who are more concerned about their diet. And so if you see ketogenic diet or any other kind of diet, they have a specific purpose. The purpose mostly is either want to reduce weight or you want to achieve something. So I think when we are anybody who is want to go for any health regime or any kind of diet, they need to keep in mind what is the objective of their health or their health goal. What is that? And my point with the designer diet is that I don't want to go with that because of that. Is it really sustainable? Can we sustain it for the long time, whether it is a ketogenic diet or anything? Another thing is that on designer diet is specifically the Atkins diet and the others the reviews have shown a lot of impact on the its toxicity because of the specific focus on a nutrient, either fat rich or a protein rich, that's specifically going to have impact on either on the liver or the kidney. So we need to be a bit very careful when a person wants to go for any kind of diet. So first is your own nutritional status and what is your goal to reach. That needs to be taken into mind when you are adopting any diet. Yes. And to me, it's not any kind of diet, it would help, but overall to achieve any health goal, you have to adapt to a healthy lifestyle. And I would really want to, rather than going for the designer diet, I would like to go for having my plate as a healthy plate, which is Harvard's recommendation also actually, including the at least 5 out of 10 or 11 food groups. That means including the all healthy options in our plate is a way forward and a sustainable way to go, rather than focusing on having a specific kind of diet which may cause harm in the long term. Thank you very much.
Yeah. Thank you so much, madam, for those very, very useful inputs. And sometimes we have these Mediterranean diets, they're specially designed like DASH or diets. And I think that they are specially designed something, to reduce the disease risk, that we're going to take more of plant-based fruits, fresh vegetables, and whole grains and all. So they're much, much better than those traditional Western diets. So I think some may be useful and some may not be really useful to us. So Dr. Asha, why women of, what are the variables if you have, Dr. Archana, what are the variables, which affect nutritional status of Indian women? Are there certain variables? We're very much bothered about them. Dr. Archana?
Actually, as Dr.
Yeah.
Yes. Thank you very much for giving me this opportunity. Am I audible?
Thank you. Yes,
okay.
Yes.
And according to WHO, as Dr. Jyoti said, the good nutrition comprises a balanced diet and the regular physical activity. It also emphasizes that the poor nutrition lead to loss of immunity, which increases susceptibility to the disease and affects our daily life also. The study, the latest family health survey with UNICEF has showed that malnutrition and anemia is still the huge health challenges for our country.
Yeah.
And this study has also showed the relationship between the malnutrition and anemia, which is correlated with the women's education, women's residential status, then women's religion, eating habits, and wealth index of the family. And the percentage of under and over nutrition are also almost equal. Specifically, the education and the eating habits were found to be influencing the underweight, overweight, obesity, or anemia like that in the family. And the nutritional status of of a lady was also found to be the dependent on the household income, household activities. And second most important thing is the poverty and the traditional values. Because even in modern era, even in the joint family, the lady is the person in the family who eats in the end and in the last. And sometimes gender inequality, then patriarchal society, traditional taboos, women education may be slightly on the lower side, even in sometimes in urban areas. So these are again a reason why the women do not pay attention to their own health and nutritional requirements and needs.
Yes.
And that is again a reason. And these are the most important variables, what I feel.
Yes, I think those taboos, ritual observances, and so many things really keep us, away from all these things. So, Dr. Asha, why women of India, you say, they require priority for nutrition? Why we need to focus on our Indian women's?
Dr. Archana has just enumerated a lot of inadequacies in our system, But why women of India require priority? Because not just of India, everywhere in the world, women are the ones who are going to get pregnant. They are the ones who have the burden of progeny, and therefore they require a certain baseline status. An unhealthy mother creates an unhealthy child. We want our next generation to be healthy. Other than that, these days, there's so much of a question of equality. Men and women are equal. Now, a woman wants to be in every field that a man is there. But for that, she has to be healthy. You cannot, just today I saw a girl, she's 26 years old, 145 centimeters and 99 kilograms. Her BMI is 46.4. And I work from 6:30 in the morning up to 7:30 at night. I have no time. So the thing is, women of India have to understand that men and women are always complementary. They are not equals. They are always complementary. And whatever you do, it is the woman who's going to get pregnant. And so you have to take care of your health. Also, in the villages, milk, fruits are not easily available. What has happened is people think that fruit means apples, fruit means grapes, fruit means pomegranates. That is not the case. Any local seasonal fruit is good. But, that image that in my mind that, it's only these things that are fruits. So they are not consuming them. Milk in the villages, 70% of our milk is produced in the villages. But even the people who produce the milk don't keep any milk for themselves. They sell it to get cash. And therefore, they are not consumers of milk, though they are producers of milk. So what is happening is that somewhere health is not a priority in the whole system. Ask anyone. If the company is giving them insurance, then it's fine. But otherwise, do you keep some amount for your health, to eat healthy, to, get a regular checkup? The answer is invariably going to be no. So adding to what Dr. Archana said just now, I would like to add that women need to give themselves importance first. Before anybody else gives them importance, they need to give importance to themselves. That psyche where a woman alone in the house will not cook for herself. She will not cook. Even if there is a dog, she will think what to feed that dog. There's a parrot, she'll think what to give to that parrot. For herself, she will not cook.
She has to be told.
She has to give herself importance that my life, my body, my health is important. If I do not give importance to myself, nobody can give it to me. If I have backache, my back is going to ache. So I have to take care of it.
I
Their
think
sight
Dr.
has to
Asha,
be changed first.
yes,
This
so
is
I
the
think
best thing.
we need to project into her mind that she is the head of the family now. So then she'll take care of herself, she'll take care of everybody. And the main thing is India suffers, women eat the last and the least. And look at the smiling face, you know, she's going on serving and serving and serving.
No,
And I think that's
actually,
one
they
factor.
eat last most of the time, working women, because they
And
don't
the
want to
least.
cook again. They don't
And the
want to
least.
cook again.
Yes.
Sabko baat diya, whatever is left is what they are having, because they don't want to cook more.
Yes.
If it remains, what will we do with it? It will get waste. Thoda kam bana lete hain, we'll adjust. That
Yeah.
is the mentality.
So thank you so much, Dr. Asha. We got so many inputs and we need to push along these women so that they take care of themselves. And Anupama, is BMI a screening tool for the nutrition status?
So, ma'am, BMI, it is used as a first-line screening biomarker for nutritional status assessment. The reason is all you need is the height and the weight of the person. Its advantages that it is because of its low cost, simplicity, and it's a non-invasive method.
Yes.
But it has its own limitations as a marker of malnutrition and also as a marker of obesity, because it is influenced by age, gender, comorbidities. And the other thing that is important is that BMI, it positively correlates with cardiovascular diseases, diabetes, hypertension. We know that the higher the BMI, the more prone the person is for diabetes, hypertension, and of course, cardiovascular risks. Also, there are, as most of us are surgeons, we know that even surgery gets complicated, with people coming to us with high BMIs, and the outcome is also, adversely impaired, because they are prone to increased length of stay in the hospital. There is a risk of readmission, wound gape, and wound infection.
Yeah.
So all this is a problem.
Yeah, I think with this BMI being useful, we can just grade, the malnutrition. Malnutrition could be due to underweight, it can be overweight. So I think it's a good screening tool. We can just put our patients, grade them, and just start working on them. And we need to go to the Sustainable Development Goal, that is end all forms of hunger and malnutrition by 2030. So working on this, we come to Dr. Manoj. What's your view on adolescent nutrition? How would you tell your adolescents yes, and why do you need them to be there with the nutrition, good nutrition?
Thank you, Dr. Ritu, for this question. This is very, very relevant topic for today's times. We see the young generation, they are like, they don't eat breakfast. They are more into the junk food. They are having the cold drinks and all. So, or sometimes like they are the fasting or something like that. So it's very, very important that at this stage, when they are growing, they need a proper balanced diet, which helps them to grow. Because as we all know that in this, there's at least 40% of the weight gain is during this time, and 15% of the adult height is attained during this period. So it's very, very important that they take a very, very balanced diet, which has a calcium, vitamin, potassium, fibers, proteins, and everything. And we are seeing more and more anemic youngsters these days, even though they are from a good socioeconomic background also. But still, the balanced diet is very, very important, which should consist of green vegetables, fruits, and all. So youngsters these days, they don't want to eat fruit, they don't want to eat green vegetables, or they don't want to consume milk. So instead of that, they go for the junk food and all. So proper attention to the adolescent is very, very important for their growth, because whatever they are eating, and that will decide their future health status when they grow as an adult.
Yes, I think we need to be very, very friendly to them. They will not listen. It's a way-wise stage, and they won't be listening to us. They'll be listening to the friends rather than us. So we need to put a little of the friendly counseling to them, that they really require vitamin C and iron and all, and just create certain foods for them. Some mothers, I've seen they make certain dishes especially for the kids and not going to eat anything, but they take care that they have adequate amount of proteins, vitamin C, iron, and everything. And sometimes they go to those fast food.
In this stage, they are more like taste buds, whatever which they find very tasty.
And they'll go to those shops, where you get pasta, where you get those Chinese and all these things. But they keep frying in that same oil, as Ravati madam said, trans fats, and there is where they start getting all those, and they start putting on weight. They get obese. They think, and some of them are on the slimming stages. So they say, we won't have, and so we'll get a slimmer. But it's not so. It's because
very important that whatever the nutritious
it's because they are missing on their meals.
Yeah, so it's very
And
important. Whatever the
Jyoti,
nutritious
what's
food
your,
is there,
take home? When they miss meals, I think they're more cravings and they tend to eat more rather than lose
yeah.
weight.
So
So,
it's very important that whatever the nutritious food are, we also increase something like we make it more tasty. So
yeah,
that's the nutrition should not be bland, because at this stage
yes.
they really want the taste bud to be satisfied.
Correct, correct. So thank you, Dr. Manoj, for enlightening so much. Dr. Jyoti, your photo of maternal and child nutrition. So pregnancy and nutrition, what you guide for our pregnant women. We need to take care, I think, all the trimesters. So
Definitely, we need to take care of the nutrition during the pregnancy. Even before pregnancy, we must start at preconception. Some of the speaker must be speaking on the preconception nutrition. So attaining optimal weight is the target, and the during pregnancy we want to have a optimal weight gain, and the prevention of the complication as well as the prevention of anemia is the major things which we really would like to achieve by the balanced diet. And as in terms of diet, the first trimester should focus on having the adequate, at least meals, which is having the very diverse diet. When I say diverse diet, it should include adequate at least 5 out of 10 food groups. That means the fruits and vegetables of different colors. And as a counseling, I always say is how colorful your plate is. How colorful your plate means how much colors in your plate are, how many reds, how many yellow, white, and green, etc. So I think having a different colors of foods and including different food groups in the diet, and also the adequacy is important. In the first trimester, the dietary quantity of diet would not increase, but second trimester onwards, there is a need to increase the amount of diet which is consumed by pregnant lady. So including additional snack in a during the day is important, and during last trimester, including at least 2 nutritious snacks apart from all 3 meals. That means having a breakfast, lunch, and dinner, and the 2 additional nutritious snacks are recommended for having a healthy pregnancy weight gain, and also having a proper pregnancy outcomes.
yes. So thank you so much, Jyoti, for enlightening us, on this. And I think, there's so many colors you told us. This, I think, when she's in the periconceptual period only, and we should put these photographs, she should have it in front of her mind. She gets that inspiration, to take a pregnancy, how to take it, carry it forward. And so much critical it is, that growth and appropriate, so much of energy, protein, everything you told us that we really require all these things. And I think this healthy diet pyramid again, that you told us, so many servings, fruits and everything should be there, so many calories and a good weight gain. So then she turns up to be having a healthy pregnancy, and this page should be in front of her. Yes, this is 60% this and 30% and 40%, whatever Jyoti told us, we need to take care. But now she's delivered. Okay, now this was very important, drink 1 glass of milk every day, 1 cup of curd, take morning sunlight, take green leafy vegetables, take 1 cup of ragi. So I think this is a very sweet chart she should keep having, around her rooms, what I have to do today on this left wall and the front wall and the right wall. And she'll have a good feeling, and I think it'll burden less of our burden, So take more food, take whole grains, as you said, plenty of vegetables, avoid all superstitions, cross to all taboos and everything. So I think that takes a go to the pregnancy very well. So Dr. Jyoti GS, we are afraid of this malnutrition. So can we break this intergenerational cycle of malnutrition?
First of all, let us understand what is this intergenerational cycle of malnutrition. A pregnant lady who is malnourished, definitely she'll deliver a stunted or a malnourished baby, and she or he, or let us take it's a girl child, and she will go on to become a malnourished adolescent, and she gets married, malnourished woman, again becomes pregnant, again a low birth weight baby. So we have to break this cycle. Because when we break this cycle, we have to break the cycle means we have to identify all the high risk factors, like, for example, where there is maternal undernutrition. That is one thing. And another thing is increased parity, frequent childbirths, and then teenage pregnancies. All this should be stopped, because eventually they will deliver again a low birth weight baby and a preterm level. So what is a very important indicator? When you see a malnourished baby, less than 2 years, then you have to relate it to this feeding practices. So very important is optimal maternal nutrition and infant and child feeding practices. So during pregnancy only, we should tell them the importance of breastfeeding and prepare them for breastfeeding, and all the practices. Immediately breastfeed the baby within an hour. Okay, and then breastfeed exclusively for 6 months. And then after 6 months, they have to be put on appropriate complementary feeds, but continue to breastfeed for 2 years. So this is very important, especially the UNICEF and the WHO says the 270 days in utero and the 2 years of the baby is a very important or a critical window period where we should see that appropriate nutrition is given, so that to break this chain.
So I think, Dr. Jyoti, to break this cycle, we need to take care of these 1,000 days. I think that's being stressed a lot. And these 1,000 days are very crucial. And for the developing, and a strong mechanism should be there to take care of the future of our country also.
Yes.
So you said exclusive breastfeeding. Dr. Archana, do you want to say anything much for lactation? She's delivered. Nobody's going to bother now. Okay, everybody's happy with the child. Nobody's going to take care of her. But she needs to feed the child, because Jyoti says you give her exclusive breastfeed. So what does she need to take care now?
Yes,
Dr.
yes,
Archana?
madam. Thanks for this question. Thank you very much. The actually lactating mother also requires an adequate nutrition to enable the synthesis of the breast milk. And a well-nourished mother creates around 800 to 1000 ml of the milk per day. Whereas in case of severely malnourished mother, the level may go as low as 400 ml only. Dietary factors, psychological, social factors, endocrinal functions, they play quite a lot the role in this.
Yeah.
Lactating mother actually requires a well-balanced diet, including proper proteins, carbohydrates, especially whole grains, then milk also daily, and the proper hydration of the mother is very, very important, what I want to say. One should also consume periodically the fruits and green leafy vegetables to get better milk production and good let down effects. Then vitamins are really essential for the baby and to get system in the mother to function normally after the delivery. Food should be rich in calcium, iron, as mother loses a lot of blood during the delivery and needs to replenish the iron stores. Then calcium is also needed to replenish the lost calcium from the body. Lactating mother also requires galactobags like shatavari, etc., which helps in increasing the milk production. And it is helping to meet us the growing needs of the baby. One should avoid non-aerated drinks, caffeinated drinks, smoking. These things should not be there. And one should also avoid using the things which are not properly digested. Like there is problem with the digestion, like legumes like rajma, chana, soya bean, etc. And some of the vegetables like cauliflower, broccoli, etc. So these things, if they are being avoided and a proper nutritional balanced diet is being taken during the lactation.
That means we cannot leave these mothers. You know, she needs in the first 6 months much more calories than in the next 6 months. So we need to take care and just frame a diet for her so that she feels it easy, what she needs to eat and what she can avoid also. So, Dr. Asha, improper nutrition and lifestyle diseases. Do you agree?
Yes. As I said, when I answered you first, Dr. Ritu, that our whole body comes out of our nutrition, everything. So also when we are talking about epigenetics and genetics and all the tumor markers, everything actually has its basis in nutrition. So if there is improper nutrition, there is going to be lifestyle diseases. We have discussed here in this session polycystic ovarian disease, infertility. We have also discussed cancer, menopausal osteoporosis and all. And other than that, being underweight or being overweight, obese, tooth decay, high blood pressure, high cholesterol, heart disease, strokes, type 2 diabetes, osteoporosis, some cancers, depression,
Yes.
eating disorders, and if you have certain sensitivities, so then you might have immune disorders, you could have celiac disease and your nutrition suffers. So, you know, everything in the human body is connected to nutrition and lifestyle.
And I think
So-
you mean to say that the non-communicable, it is a, I mean, it's a killer. So
it is a killer.
And they are not contagious, right? So we can take care of them. Is there?
Dr. Ritu, one thing, I think they are contagious.
They are contagious? Okay.
Yeah. You remember a family of obese people, and you know, they say obesity runs in our family, and the answer is that actually nobody runs in our family. So all of them have the same eating pattern, they have the same lifestyle, they have the same taste.
Yeah.
And you have the entire family obese.
Yeah, and another thing that we need to take care is a nutritional transition. We need to switch to plant foods, you know, rather than sticking on to those animal foods and all. And Anupama said, you know, WHO says you take 400 grams. So we need to take care. And the salt that she said. So it's 5 grams per day. That means just a spoon. So are we taking just a spoon? So we need to take care. But RDA says 6 grams. So just a little difference. And I think the small things, if we take care, they're going to make a lot of difference, as Dr. Asha said.
Once you are perimenopausal, I think your requirement is down to 3 to 4 grams only.
Yes, yes.
It's
So
like
that's
that.
there. So Dr. Anupama, I want you to give us some tips, fast tips for nutrition in obese patients. What do these patients do? They say, I'll not eat. I'll not eat. I don't eat anything. You know, I don't have my meal. अब मैं थोड़ा खाती हूँ, एक चपाती खाती हूँ, फिर भी मेरा weight नहीं कम होता. What do I do?
So, ma'am, the first thing, as Dr. Asha said, they should start running. The entire, lifestyle modification is very important in women or in young girls who are, obese PCOS. So according to the 2018 PCOS guidelines, there is insufficient evidence to suggest that there is any specific dietary approach, but they do recommend a balanced diet. And that, of course, is according to the individual's lifestyle and the needs and preferences. So they should, eat more of low carbohydrates, foods which are low in glycemic index, like brown rice, oats, barley, legumes. Of course, they should include monounsaturated fatty acids instead of the trans fatty acids, and have a high protein diet, because all this will help in weight loss and it will improve the hormonal milieu. That is very important in women with PCOS, because what we want is that their menstrual cycles should be regularized. So even a weight loss of 5 to 10% will help in regularizing their cycles. Another thing is that there was a systematic review which included around 1,200 participants, where they looked at the DASH diet, that is dietary approach to stop hypertension, in patients who are obese PCOS. And they said that if they have this diets which are rich in fruits, vegetables, whole grains, etc., then it may help in reducing their insulin resistance, and also it will bring down their SHBG levels. So as compared to a controlled diet, a DASH diet is beneficial if taken for around 8 to 12 weeks. As far as the proteins are concerned, then even a higher protein intake is helpful in suppressing the androgen levels when you compare it to a high carbohydrate. So we have to advise them on a proper diet, as well as, stop all these fast foods and pizzas and burgers, etc. So that is important for already they are obese, they need to lose weight. That is important.
Yeah. So Jyoti, I want to add certain things. These patients, PCOS, they need to take care. They cannot be fasting for a long time. They cannot have heavy meals. So I say small, frequent diets. They have to avoid those insulin spikes. Correct? Jyoti, do you agree with me? They need to avoid the insulin spikes. So they take small diets at a time, and they need to take whole grains. The unprocessed food is much more important for them. And of course, a rich fiber diet is very important. And a lot of things Anupama told us. So we need to push our patients of obesity to follow all those tips. So Dr. Jyoti GS, what are the essential, Mike? I want to make my immune system very strong. Just tell me few micronutrients I need to take care. I need to be strong immunity-wise.
Micronutrients which are important for boosting immune system. We have these vitamins, vitamin A, C, D, E, and then we have B6, B12, folates, which are B9, and then zinc. There's minerals such as zinc, copper, selenium, magnesium, iron. They are all essential micronutrients which can affect the immune status. They act from almost so much important they are that they have this antioxidative effect, and they also help in the functioning of the T cell lymphocytes and antibody production. And they also maintain the skin barrier. They produce this help in innate immunity and integrity of this cells of the respiratory system or of the skin. And they are really helpful even in cell-mediated immunity, boosting that. And whenever there is infection, as I told you last time, that they boost up a response.
Yes.
And they are really integral to my function, to make the immune.
So being a little short of time, I would like to push on. Yeah. Thank you, Jyoti. So Dr. Manoj, they speak a lot about omega-3 fatty acids. What do you think? Is it suitable for your preeclampsia patients? Should we advise them? What is the benefit?
Yeah,
you
definitely.
push them with ecosprin, you push them with arginine. Does this have an effect?
Yeah, definitely. Omega-3 fatty acid does help in preeclampsia patient, but it's better they take in a natural form like cod liver, this thing, fish liver, fish oil, and other things. But when they are taking oral extra supplements, then they should be very careful that they should not be taking overdose. So that is very, very important.
Yeah, so these are very important because, they act by being inhibitors of two series eicosanoids, TXA2, and they also act as antioxidants by vasodilation and decreasing the platelet and leukocyte activity. So I think they are helpful for our patients and we should give them. Dr. Jyoti Sharma, now, you know what? Brain fog, I forget. I don't know what to do. Can you suggest this menopausal women that they lead a better life? Everybody, curses them. Aapko bataya tha, you're not remembering. You've left your gas open. You've left this, done this. Every time a curse on them. So please suggest us.
This is very important, and I'm thankful that we are discussing that. Nobody discusses this even. We have never thought of that. That can be a very important thing. So one thing is that I think when by the time we are reaching to the women is reaching to menopause, this counseling has to be done that slowly they need to shift their diet from the cereal and the processed food to a little unprocessed foods, and including lot of fruits, vegetables, and the sources of omega-3 fatty acids.
But some foods, which are very important, I'll just guide them. You take this much, this much. So some important foods.
I'm just coming to that. So to my mind, first thing comes is the flax seeds, which are really, really important. And of course, the salads which we are now recommending different kinds of seeds, which includes which are good source of both and three fatty acids, which are really important to keep up the cognitive functioning. And also the foods which are rich in antioxidants, like the broccoli or the green leafy vegetables. Also the berries, which we are talking, I think Dr. Revati was talking about it, is the different kind of berries are available, which are actually help reducing sugar spikes also, and help improving the cognitive functioning by providing us the antioxidants and flavonoids, which are important for the improving the cognitive activities. Also, it is also important, along with the diet, the women has to focus on improving the activity. The active adoption of active lifestyle is going to be important to beat this cognitive decline after menopause.
Right. And I think walnuts.
Yes.
She showed the pic of the walnuts.
Tell them to have those. I think they have
Yes.
a lot of alpha-linolic acid and all that.
Yes,
So,
yes. Yeah.
cognitive loss will not be there, and they'll be very happy. Once they
Yeah.
are pampered by the family, after that, they start feeling happy, and flex seeds and all, as you said. So, but we cannot forget, the WHO global targets. So, Dr. Archana, what are the WHO global targets for 2025? Improving the infant, maternal, and young child nutrition.
Thank you very much for this question. A WHO Assembly resolution in 2012, they have endorsed a comprehensive implementation plan of the maternal, infant, and young children, which specified a set of 6 global nutrition targets, that is by 2025, and that aims for to achieve around 40% reduction in the number of children under 5 years who are stunted, then to achieve a 50% reduction of the anemia in the women of reproductive age group, then reduction by 40% of the number of children under 5 years, yes, I have already told, then to achieve a 30% reduction in low birth weight babies, then to ensure that there is no increase in the childhood overweight, that is very important, and to increase the rate of the exclusive breastfeeding in first 6 months of the age at least by 50%, and to reduce and maintain the childhood fasting to less than 5%. That is very important.
Yes.
These are the targets given
yes,
by.
I think these are wonderful targets, and I think we need to keep focused on all of these. Once we are focused, we can all help him to achieve these targets, and I think we need to work on them. And this is the stage of nutrition that we need to take care for each and every. Plan all your healthy, keep this plate and vegetable, fruits, everything has to be in front so that we keep putting our plates like this. So thank you so much. I think we went off quite well and in time for this session, and thank you all my panelists for this wonderful contribution. We had learned so much, so many inputs by each one of you, and I think we took it around through all the ages. We covered a lot of points. We learned so many things while doing and reading all these things. So thank you so much to all my esteemed panelists for being a part of this panel discussion, and I think we are right on time. And I think we finished. We have Dr. Lakshmi. Thank you, Dr. Asha, Dr. Jyoti Sharma, Dr. Jyoti GS, Anupama, Dr. Archana, Dr. Manoj. And we missed Dr. Vidya, madam, for her expert comments. She just messaged me. She'll not be able to. She's in Pune. So I think some joining. And Dr. Asha, thank you. So Revati, madam, thank you so much for being with us till the end. And a lot of wonderful presentation from yours. And I think we had a lot of learning points. We have Dr. Lakshmi with us. We can have Jignesh. We can have the post-test.
Yes, ma'am. We'll post it now.
Yeah. So we are on time. I think 6:50 was the time for the post-test. So we are right on time.
Thank you, Dr.
Thank
Ritu.
you, ma'am. Thank you very much, Dr. Ritu.
Thank you,
so
Dr.
nice to
Ritu,
be
for
with
giving
you
us
all
this
again.
opportunity. And it is a wonderful ICOG certification program. We have learned a lot in last 3 days. And it was you to get us engaged for this program. Otherwise, for the webinars, we are slightly reluctant.
Yes. So we all came in. We pulled in so many things. Thank you so much. We can have the post-test on, Jignesh.
Thank you, Dr. Ritu.
Thank you. Thank you, Dr.
Thank you.
We have the link on for the post-test.
Yes, Ritu, you will have to tell the correct answers.
Yeah.
Yes.
So Jignesh,
Either
can
you
put
share
that?
or Jignesh will share. Yeah.
Jignesh can share. We've sent it to him.
Jignesh, karo.
Indications of TPN, total parental nutrition, are all except the correct answer is terminally ill patients. Complications of TPN are catheter-related metabolic infections, all of the above. All of them are the complications of TPN. Advantages of total parental nutrition are all except there's increase in weight, there's improved hydration, correction of vitamin deficiencies, improved clinical outcome. So except is improved clinical outcome. All of the other modalities of nutritional therapy except parental nutrition, enteral nutrition, oral dietary, therapeutic nutrition. So it is therapeutic nutrition, which is the correct answer. Etiological factors of malnutrition in cancer patients is caused by decreased food intake, it's malabsorption, it's a wasteful metabolism, it's all of the above. So all of the above, all the factors add. According to the subjective global assessment for nutritional status, patients are classified into categories 2, 3, 4, and 5. So it's 3 is the answer. 3 categories. Single most useful parameter of the nutrition status is a change in weight, it's edema, it's a mid-arm circumference, it's change in height. So the correct answer is change in weight. The basis of nutritional assessment are all except anthropotic parameters, serum protein, immunological test, and hemoglobin. Hemoglobin is the exception. Nutritional status of gynec onco patient should be assessed at the initial diagnosis. It should be before the therapy, it should be end of the therapy, or throughout the treatment and post-treatment. It's throughout the treatment and post-treatment. Malnutrition is an important issue in which gynecological cancer? Is it cervical? Is it ovarian, vulval, or endometrial? It's an ovarian cancer. Deficiency of dash and dash can be seen even without weight loss and can contribute to significant morbidity. Is it magnesium and calcium, magnesium and B12, vitamin D3 and magnesium, vitamin A and B12? It's magnesium and B12. In midlife, increase in the intake of saturated fatty acids. Midlife increase the intake of saturated fatty acids. So it is false. Good dietary source of lycopene is watermelon, carrot, tomatoes, all of the above. It's all of the above. In vitamin D, exposure to sunlight is the best at what time? Is it 8 to 10, 11 to 2, 4 to 6, or 6 to 8? The best is 11 to 2 p.m. All are true except flex seeds are the best source of antioxidants. Avoid large meals before bedtime. Include biscuits with the trans fatty acids. Broccoli has hero-protective benefit effects. So the correct answer is include biscuits with trans fatty acids is not true. Whey protein minimizes sarcopenia. Is it true or false? It's true. Macronutrients are vital in infertility as they provide energy, catabolic anabolic process in generating ROS. So they are involved in the catabolic and the anabolic process. Mitochondrial DNA is particularly prone to ROS due to the presence of oxygen in the ETC. There's a lack of histone protection, absence of repair, all of the above or none of the above. It's all of the above. Vitamin E is a potent radical scavenging antioxidant. How does it act? It acts by inhibiting lipid peroxidation mediated by free radicals and enzymatic oxidation by lipoxygenase cycles. So it inhibits lipid peroxidation mediated by the free radicals. Adequate folate levels are important for the oocyte quality, maturation, fertilization, implantation. It's true or false? It's very true. Antioxidants protect DNA and other vital molecules against oxidative damage that would otherwise induce apoptosis. That is true. Vitamin D deficiency is associated with conditions that decrease fertility, such as PCOS, and adversely affect the outcome of infertility treatment, such as IVF. So that is true or false? It's true. Most important broad spectrum antioxidant, which has a role in female infertility, the broad spectrum antioxidant, carotene, vitamin C, E, melatonin, it's melatonin. Evidence of oxidative stress induced damage in PCOS are all except. So the evidence is high DNA damage strand breaks, increase in the MDA levels, and a higher C-reactive protein because it's a biomarker of inflammation, increased level of glutathione. So increased level of glutathione is not an evidence. So this is the correct answer. Effects of supplementing with micronutrients that have antioxidant effects B2, B6, C, and E, copper, magnesium, selenium on the levels of the oxidative stress and subsequent outcomes in the IVF in older patients more than 39 is significant increase in the mean number of good quality and a better ongoing. Yes. So the aged patients also need to be given these antioxidants. So it's true. N-acetylcysteine is a powerful antioxidant and has been used as a cofactor for ovulation induction. True or false? It's true. Even with the clomiphene and letrozole, we use N-acetyl. Lycopene improves sperm parameters. How is it? By preventive oxidative damage to sperms, providing extra energy, maturing them faster, concentrating. So it's an antioxidant. So preventive oxidative damage to the sperm is the correct answer. Zinc deficiency is associated with decreased testosterone levels and sperm count. That is true. So it is needed as a supplement in these patients. Increase in the levels of CoQ is observed in the sperm cells and seminal fluid of idiopathic and varicocele associated asthenozoic patients. Is it true or false? It's false because these patients have decreased levels of CoQ. L-carnitine improves sperm motility by providing energy to the sperm through fatty acid metabolism permeating through cell membrane, decreasing fat consumption, breaking of protein. It acts to the fatty acid metabolism. So that's the right answer.
Thank you, Ritu. And as ICOG chair, I am immensely satisfied after this 3-day course of nutrition in women. And on behalf of ICOG, I would definitely like to thank the course convener, Dr. Vidya Thobi, and our co-conveners, Dr. Ranjana Khanna, Dr. Kiran Pandey, and Dr. Ritu Khanna, for meticulously conducting the day-wise proceedings and for successfully completing the pre-test and post-test on all the days. And I'm sure, Ritu, everyone will agree with me that this course was an eye-opener that nutrition is really so very important for at least we OBGYNs.
And every day, madam, there was something new.
Yes, we are catering to the woman during their crucial milestone things, that is adolescent, infertility, pregnancy, lactation, midlife, old age. So, I mean, I was very keen that we should have a dedicated course on nutrition in women. And I'm so happy that Vidya, she prepared a module covering all the aspects which are very important for us, that is we OBGYNs. And friends, I'm seeing a lot of queries. Yes, the recordings, YouTube link will be uploaded on ICOG website very shortly. So those who have missed it, those who wants to revise, they can log into our ICOG website and they can go through the recordings. As far as certificate is concerned, we have already clarified that who are eligible to get certificate. So ICOG office will go through the entire data, and those who have cleared all 3 days post-test with 50% marks, they will get their certificate on their email. So I think we should be saying goodbye here, and next month we are again having a very useful 3-day course on safe abortion practices. So do log in, and I will again encourage each and everyone to go on our ICOG website. We have uploaded our calendar for the month of April and May, so that you should not miss any of the academic event which ICOG is having. And all the events, all the webinars, courses are totally free of cost. You just have to visit ICOG website to get all the details and the links to join these courses. Yes, Ritu, you can say, and then we will wind up.
Thank you. Thank you so much, Lakshmi Madam. And we promise we'll come up with the ready reckoners for all these, because they'll be very, very helpful. You know, it'll be in short that we'll remember. And so today, I think with this course, we reintroduced healthy eating habits for longer and better lives. The meal planning, the healthy nutrition, they're so important. And I think even these small changes, they'll make a big difference. So we can make our life free from, I think, the non-communicable diseases. So thank you so much, Madam, once again. And thank you all the participants and all chairpersons, everybody. So thank you. Thank you so much.
In certificate, Ritu, it takes time. Yeah, you will get within 1 month. So just have patience and you will get the certificate in due course of time. So yes, Jignesh, you can stop the recording, and please, we will say good night to each and everyone.